So what is the trend so far and what you can expect now? Okay, the trend at present is out of 200 MCQs that I looked into, general pathology constituted for 37%, whereas hematology and blood transfusion constituted for 29%, systemic pathology 18%, and clinical and practical pathology constituted for 15%. So if you look into this carefully, you have an idea now that where you have to concentrate. That's definitely in general pathology as well as hematology and blood banking concepts, right? So the same trend you can expect, because most of the times in INI-CET, what are the questions you're getting is from general pathology, followed by hematology, and then systemic pathology, and some questions on clinical as well as practical pathology. Now, what you can expect and what is the trend in general pathology? You can see that most of the questions are from immunity, followed by neoplasia, cell injury, inflammation and repair, amyloidosis. Very few till now from hemodynamics, and of course, a very good number of questions from genetics and from infections. So, these are the key areas where you are going to concentrate, and most of the questions are concentrated around immunity as well as in the concepts of neoplasia. Okay, so that's where you have to give the maximum emphasis. And moving on to hematology and blood banking, what you can expect there is mostly the anemias, especially the nutritional anemias. Every the examination has question on iron deficiency anemia, anemia of chronic disease, megaloblastic anemia, and hemolytic anemia. So those are the very sound areas where you cannot ignore, right? You have to read and you have to be thorough there. And then followed by leukemia, Hodgkin and non-Hodgkin lymphoma, and some questions even on bleeding disorders as well as blood banking. In systemic pathology, what is given the maximum importance is, one is the urinary and male genital system, specifically the disorders of kidney as well as the male genital system, where we have the tumors of testis. Next is GIT, okay, colon cancers, the polyps of colon, all have been asked right and left. In endocrine, most of the importance is given to pathology of thyroid, and then we have questions from RS, respiratory system, where most of the questions are from pneumoconiosis or from lung cancer. In CVS, you have questions from cardiomyopathies, or you have questions from myocardial infarction, and very few questions from hepatobiliary system, mainly related to liver function test. And then we have questions on soft tissue tumor, where most important is schwannoma. Then we have few questions on bone tumors and skin tumors, mainly in the form of basal cell carcinoma, which is an image based question, and then also some on this pemphigus vulgaris as well as bullous pemphigoid. So this is so far the trend, and a lot of topics in clinical pathology and lab hematology and cytology should also be given importance in the form of blood collection tubes, that is simple vacutainous. Okay, they sound so simple, but then when the question is asked with the multiple choice way, you have a lot of confusion there and it's difficult there. Okay, then collection, the cell counting chambers, diluting fluids, hemoglobin estimation, then thyroid function test, liver function test, urine cytology, mainly the appearance of those crystals, which is again a image based question. Pap smear, many questions have been asked till date. Special stains, immunohistochemistry, these are the ancillary techniques, that is IHC, flow cytometry, FISH. Many have been asked as image based questions. You have immunofluorescence as a technique wherein you have to diagnose a renal, that is a glomerular disease as well as the skin disease, and serum or antibodies in the pattern, whether it's a speckled pattern, diffuse pattern, etc. Even that's been asked many a time. So you need to concentrate on all those topics and then decide to what area you're giving more weightage, and then you plan your revision, right? So now what's the flow? If you ask me this question, this is not going to be a very systematic one, like I start from cell injury, then I go to inflammation, then I go to systemic pathology, then I go to lab medicine. It's not like that, because just to sensitize you to this potpourri, that is a mixed bag, right? If you are dealing with systematically, your thought process may not jump from one area to other in a very rapid way or a very transient way. So to sensitize that, I'm actually mixing everything, but yes, it's going to be year wise, and then in that, general comes first, then comes systemic. If not, it is chapter wise. Okay, so moving on to one mandatory element that you have to know is the autosomal dominant, X-linked recessive, autosomal recessive mitochondrial disease, which have been asked in all the exams, mostly in the form of match the following. Now let's try to solve the simple match the following, right? What is autosomal dominant in this? All of you know it is myotonia dystrophica. What is X-linked recessive? X-linked recessive, everybody will answer this as Duchenne muscular dystrophy, even Becker muscular dystrophy. Again, what is autosomal recessive here? You all know that it is cystic fibrosis, and mitochondrial is Leber's hereditary optic neuropathy. So this task of remembering all this is not usually possible without a mnemonic, or you have read it many times. Okay, so whenever this match the following comes, always try, if you have a mitochondrial disease where you have limited sets like Lee's syndrome, Leber's hereditary optic neuropathy, try to match that first, and then go to X-linked recessive where ABCDEF becomes the mnemonic and you can easily match it. Then you can go for autosomal recessive, which is usually an enzyme deficiency disease, and autosomal dominant comes the end. So there are certain mnemonics you can follow, whichever you want, but I usually follow Marfan, Erler, Huntington predominate in the family at Orlando, wherein most of the diseases which I've listed as an autosomal dominant inheritance pattern comes there. Okay, so never forget about this Huntington disease, myotonic dystrophy, familial polyposis coli, achondroplasia, familial hypercholesterolemia, acute intermittent porphyria. This is very important that you see it in the last minute every now and then, so that you don't miss such easy questions. Okay, it's purely concept, it's a memory based, it's fact, right? There you can't lose your marks. So please make sure that you learn every disease in this particular table or the chart which is given here, and then try to match it perfectly, right? This is about autosomal dominant. And one more question which is possible is pedigree of autosomal dominant. What you have to observe here is there is no skip pattern. Males and females are equally affected. Can you see that? Males and females both are affected. There is no skip pattern. There is no generation skip as you see in trinucleotide repeat mutations. And autosomal dominant usually manifests in the adults. There is variable expressivity and variable penetrance in case of autosomal dominant diseases. And the diseases usually affect either the metabolic pathways or the structural integrity, or they are the collagen affecting diseases, like you have some variants of Ehlers-Danlos syndrome. Okay, so this is what you are supposed to know here. When we move on to autosomal recessive, again the list becomes big, but remember that they manifest in the childhood and they're mostly the enzyme deficiency diseases. Okay, so mostly we have a lot of metabolic diseases which comes under autosomal recessive sets. I have a mnemonic here. Girls have thalassemia in pediatric ward. That is 2 girls where we have 2 Gs. That is, 1 G is for glycogen storage disease and the other G is for galactosemia. Okay, so this is how we can actually learn a lot of autosomal recessive disease, but remember they are mostly enzyme deficiency diseases. So in pedigree chart of autosomal recessive, you can again see that the carriers will be present and fully affected will be. What is the risk here is only 25%. What is the risk in autosomal dominant? It is 50%. Okay, usually the disease expression is only in the homozygous state and not in heterozygous, and heterozygous are usually carriers. So that is what you need to understand in autosomal recessive, right? Now if I show you here the X-linked recessive, X-linked dominant are very rare and few in number, whereas for X-linked recessive you have this mnemonic ABCDF. It's very easy to remember. At least try to remember Duchenne muscular dystrophy, and we have Becker's muscular dystrophy, hemophilia A, B, which is asked every now and then. Okay, and they're quite easy to remember. Now out of these 2 pedigrees, which one is X-linked recessive in nature? Can you tell me? Any one of you? So if I call this as A, if I call this as B, so which is X-linked recessive? Do we have any answers here? Good evening everyone who are watching me live, and thank you for joining. Do we have any answers? A and B, which is X-linked recessive? It's very easy, right? What happens in X-linked recessive is female is affected, only the males are getting the disease, whereas females are spared. That becomes X-linked recessive, because once the parent is a female, only male child is going to get affected, and that's not the case in X-linked dominant. So that is how you can solve this pedigree, whether it is X-linked recessive or X-linked dominant. What happens in mitochondrial inheritance? You can see that if female is affected, all children, okay, if the mother is affected, all children are affected, whereas if father is affected, none of the kids are affected. So by looking at this, you you can easily solve this pedigree as it is mitochondrial pattern of inheritance. What are the examples? Lawn, then we have Lee syndrome. This is Leber's hereditary optic neuropathy. This is most frequently asked, okay, as one of the options for mitochondrial inheritance. But then we have Lee syndrome, Mela syndrome, Parkinson's disease. So all those are examples of mitochondrial pattern of inheritance. Okay, so we have completed the Mendelian pattern of inheritance about the different diseases, and this is going to be asked every now and then, and probably for years it will be asked. You need to remember all the diseases and the pedigree charts for those things. Okay. Moving on to match the following. This is again one more important area, that's in neoplasia, where we have oncogenes and tumor suppressor genes which are related to particular cancers. Now here we look into KRAS, KIT, JAK2 and ALK1. Okay. KRAS, you are all familiar that it is related to the cancer of colon and pancreas. Okay. KRAS for colon, and then we have pancreas, and adenocarcinoma of lung is also associated with KRAS. KIT, we have a mnemonic for KIT, that is games. Okay, this is very, very important. G for GIST, G for germ cell tumor, then A for acute myeloid leukemias, then we have mastocytosis, which is again related to KIT, and S for sinonasal T cell, NK T cell lymphoma. Okay, so all those are related to KIT. So what we can match with here? KIT. KIT is related to GIST, KRAS is for pancreas. Okay, and then we have ALK1 is specifically for lung cancers, that we need to remember, and also for anaplastic large cell lymphoma, and JAK2 in case of myeloproliferative neoplasms. So this is possible only with frequent revisions. Okay, this is mainly factual, so you need to remember them. So here I have some of the lists so that I can just go through and quickly I'll revise through all of them. PDGF for glioblastoma, and FGF is mainly for osteosarcoma, and then hepatocyte growth factor, it is easy to remember, it's in hepatocellular carcinoma. And if we go for EGF receptor family amplifications or translocations, where we have adenocarcinoma of the lung, and RET again, which is very important, germline mutations which are associated with medullary carcinoma of the thyroid, even with MEN2A and MEN2B. PDGFR receptors again in case of gliomas. Remember this has been asked in one of the exams as PDGF, which has come in the match the following pattern, and wherein glioblastoma was given, right? Then ALK receptor, as we already discussed, in adenocarcinoma of the lung, and I have already told games as a mnemonic for the KIT associated tumors, right? Again KRAS, HRAS, NRAS, which are hotspots. Again the questions can be asked there. K for colon, lung and pancreas. H, okay, it's for urinary bladder and kidney tumors. NRAS is again NM, that way you can remember. So NRAS is for melanoma, and again for this ALK receptor is over. RAS signaling, this is again one more important area where we have BRAF-fomas in the form of melanoma, hairy cell leukemia, LCH, carcinoma colon and papillary thyroid cancer. So this question can be asked, what are the different BRAF-fomas that you know? Okay, so don't miss this. BRAF-fomas, these 5 tumors are very, very important. And again JAK2 mutations in the form of JAK-STAT signaling pathway abnormalities, where you have myeloproliferative disorders. So KIT mutations, I have already told that GIST, germ cell tumor, AML, mastocytosis, sinonasal NK T cell lymphoma. This is must. You must remember what are the tumors which are associated with KIT mutations, right? Moving on to the next question, which says, which of the following is not helpful in double-stranded DNA break repair? You need to thoroughly read this question and understand what are they interested in. Only not helpful in double-stranded DNA break repair. Okay, for this you should know what are the different types of DNA repair mechanisms and what are the different genes which are involved in. If I try to answer it, it is very easy because MSH2 is the one which is involved in microsatellite stability. Okay, if it is not there, it causes microsatellite instability, and because MSH2 takes care of mismatch repair and not double-stranded DNA break repair. So if you do it by exclusion also, then you are able to do it. ATM, BRCA1 and KU70, all those are involved in double-stranded DNA break repair, but not MSH2, which is involved in DNA mismatch repair. For this question, you need to actually know what are the different types of DNA repair mechanisms. So firstly, it is the mismatch repair. So what are involved in mismatch repair? MLH1 to 3, PMS1 and 2, as well as MSH1 and and 6. Okay, if they are not functioning properly, then it results in microsatellite instability pathway that we see in hereditary non-polyposis colon cancer, that is HNPCC, right? If nucleotide excision repair is defective, usually it happens after exposure to sunlight. What happens if there is formation of pyrimidine dimers? That needs to be repaired. If that is not done, then it results in condition called as xeroderma pigmentosa or cocaine syndrome. Okay, so this is also very important. Then we have something called as homologous repair, that is double-stranded DNA break repair, which was asked now, right? So for those, it is ATM, BRCA1, all those plays a very important role in the repair of double-stranded break repair, that is homologous repair. So in double-stranded break repair, we have non-homologous end joining repair. This happens usually in case of cancers where there is bridge fusion break cycles, whereas homologous repair, which happens normally, so broken homologous DNA sequences are repaired. If it is defective, then what are the diseases which can be seen? Bloom syndrome, ataxia telangiectasia, Fanconi anemia, and familial breast cancer. Again, you have all the clues related to genes which can take care of this kind of double-stranded DNA break repair. BLM gene, ATM gene, BRCA2 gene, that is BRCA2 and BRCA1 gene, also take care of this kind of double-stranded DNA break repair. Okay, so you have to thoroughly know what are the different types of repair and what are the different genes which are involved, right? Next question is 70-year-old woman, diabetic and hypertensive. The image was cardiac myocytes with some kind of pinkish material which can be seen here. Okay, the moment you see this, most of the times it's going to be amyloid. This is a congruent stain which gives brick red color after if you do a congruent. On HND, it looks like amorphous extracellular eosinophilic, that is pink material. So you are seeing some dark pink material and it is not looking like mucin like how you see in PAS. Okay, the PAS gives you what color? That gives you a magenta color. Okay, you are not seeing any magenta color. So it is not PAS and it is related to heart. The options are dilated cardiomyopathy, hypertrophic obstructive cardiomyopathy, restrictive cardiomyopathy, and atrial flutter. Okay, something related to heart are the options, and this kind of picture is given. Amorphous extracellular eosinophilic material. The moment you hear this, yes, you are actually dealing with what substance? Can anyone answer? Amorphous extracellular eosinophilic material. So what's the answer? Moment you see this description in pathology, it's going to be only one. That's nothing but amyloidosis. Okay. So this question can be twisted in many ways. A congruent stain section can be given, or apple green birefringence under polarizer. Even that image can be given. So, but what you have to answer is amyloid results in which type of cardiomyopathy? Deposition of amyloid happens. So naturally it is going to be restrictive cardiomyopathy. It's easy question if you can actually diagnose the presence of amyloid in the image. Okay. There are various causes for dilated cardiomyopathy, restrictive cardiomyopathy, and hypertrophic cardiomyopathy. You need to remember some of them. HOCM is an important cause of hypertrophic cardiomyopathy. Alcoholism is an important cause of dilated cardiomyopathy. For restrictive cardiomyopathy, it is deposition of some material in case of amyloidosis or infiltration of eosinophils, which happens in Loeffler's syndrome. Even sarcoidosis and hemochromatosis. These are the important causes of restrictive cardiomyopathy. What is more important than this in this case is actually the diagnosis of amyloid, where you can use different stains, okay, starting from HND, where I said it is amorphous eosinophilic extracellular deposits, which gives you a brick red appearance, or you use a congruent stain, which is more specific stain, okay, that's very, very important. And then you see it under the polarizing microscope, that gives you apple green birefringence under polarizer. Then you can use thiofluovin T and S. Then you can use PAS, that is periodic acid shift. It is not very specific, but it stains the amyloid material pale. Okay, that is pale pink in color. Toluidine blue, again it gives a orthochromatic blue. Remember that toluidine blue is a metachromatic stain. It's a very, very important stain. Then we have methyl violet, crystal violet. All of them yield, these are all metachromatic stains. Okay, they yield gross pink. What is the mnemonic to remember all the different stains is she looks too pretty, try to catch her, which have already shared in my notes as well as in Instagram. You can have a look into it. It's very, very important that you remember all the stains and never forget Congo red stain and apple green birefringence under polarizer. Okay, that's very important. So here is an example. This is what is the amorphous pink eosinophilic extracellular material, and this is the apple green birefringence under polarizer after doing Congo red stain. This is very important. Okay, after doing Congo red, you are going to see it under the polarizer. Now, apart from the special stains, what are the different type of amyloid proteins that are deposited in different conditions? This is again one more important question that you are supposed to answer, right? So, AL, that is light chain amyloidosis. Immunoglobulin light chain, as we hear this light chain, you know that you are dealing with primary amyloidosis, right? That's very, very important, which is related to the plasma cell dyscrasias, mainly multiple myeloma. AA is secondary type of amyloidosis, which is mainly seen in liver diseases as well as in case of familial Mediterranean fever. Very, very important. A beta 2 microglobulin, it's been asked many times. Hemodialysis associated amyloid is A beta 2 microglobulin is what you need to remember. And then familial amyloidotic neuropathy. Remember that it is mutant type of transthyretin which gets accumulated, whereas in senile systemic amyloidosis, it is normal or wild type of transthyretin that gets accumulated. Never go confused. If it is familial amyloidotic, then we have mutant variant of transthyretin. If it is senile, something age related, you can remember. That's a normal phenomena. So you have normal transthyretin which is getting deposited. So that way you can remember. In case of Alzheimer's, that is senile cerebral amyloidosis, we have A beta, then isolated atrial amyloidosis, it is mainly atrial natriuretic factor. In medullary carcinoma of thyroid, it is calcitonin, and in case of diabetes, it is islet associated amyloid protein. Okay, so this is again a very important table that you have to again revisit and try to remember all the abnormal proteins that are getting accumulated in different conditions and types of amyloidosis. And some important points in amyloidosis. What is the most common organ that is involved? Answer is kidney. Okay. In spleen, there can be sago spleen and Lardaceous spleen. Sago spleen, where is the deposition of amyloid? It's in the splenic follicles, that is in lymphoid follicles. Where is the deposition in Lardaceous spleen? That's mainly in between the splenic follicles. What do you have? Definitely you have a lot of red pulp. Okay. Geographic deposition of this particular substance, which is known as Lardaceous spleen, meaning it resembles the pig fat. Okay. What is the first site to be involved in liver? Again, one more important MCQ. So the answer is space of Deci. And what is the, in case of senile systemic amyloidosis, what is a major organ involved? Heart is the answer. What is the first site to be involved in heart in case of amyloidosis? What is the answer? That is the subendocardium. Okay, so you need to remember all these things here. And most sensitive test in systemic amyloidosis. Do we have an answer for this? Most sensitive test in systemic amyloidosis. If it is organ, specific organ, naturally if it is kidney, you will do a kidney biopsy. What if it is a systemic amyloidosis? What is the first site you are going to target for? The answer should be abdominal fat pad aspiration. Okay, remember this, very, very important. Abdominal fat pad aspiration. The next option is going to be rectal biopsy or tongue biopsy. What is the cause of death in amyloidosis? In case of primary, it is mainly a cardiac failure. Okay, they suffer from arrhythmias and other problems. So, cardiac failure, whereas in secondary, it is going to be renal failure. Okay. So again, in if it is dilated cardiomyopathy oriented, right, we finished with amyloidosis, but again, if we can't forget the heart there, what we can actually expect further in dilated cardiomyopathy is the ninja star appearance. Okay, that's very, very important. What appears like a ninja star is nucleus within the myocyte. So this is what you need to remember, nucleus within the myocyte in case of dilated cardiomyopathy if it is due to titin mutation. Very, very important. And you see myocyte disarray, meaning haphazardly arranged myocytes, including the sarcomeres within the myocytes that you see in case of hypertrophic obstructive cardiomyopathy. And if you see contraction band necrosis, this happens when there is ischemia reperfusion in the setting of myocardial infarction. Okay, so this is what you can remember. Moving on to the next question. After class switching, a particular class of antibodies produced, but IgM and IgD are expressed concomitantly. Okay, already some class of antibodies being produced, but IgM and IgD, which are present from before, are also present. So what is the reason? Okay. So is it affinity maturation? No. Affinity maturation means more and more antibodies to fight against a particular antigen. Okay, and it becomes more specific. That way, it is affinity maturation. Somatic hypermutation will actually not lead to this condition. That is, IgM and IgD will not be present concomitantly. What about alternate RNA splicing? Okay, what do you mean by alternate RNA splicing? Okay, you have this kind of the RNA which is already present, and there are exons, introns which is already there, and if you splice at or cut at different locations, you will get combination. Okay, you might get combination of pink and green, and then you might get combination of brown and blue here. This will result in what is known as the different kind of antibodies. Okay, if this is present, originally if IgM and IgD are present, they are still present, but new antibodies depending on what is required, whether IgA, IgG, that also is going to be synthesized. The correct answer in this case will be alternate RNA splicing. Allelic exclusion cannot happen because IgM and IgD are present and they are being continued. Okay, they are expressed concomitantly is the question. So alternate RNA splicing will be the best answer. What do you mean by isotype switching? Okay, so here B cells are activated to produce antibodies of different isotypes, starting from IgM, then IgD, IgG, we have IgA. Okay, so that is nothing but switching. It's very easy to remember the switch from one antibody to other antibody. What do you mean by affinity maturation? The antibody production with increased affinity for an antigen. That is nothing but affinity maturation. These are some of the important terminologies that you are supposed to know. Okay. Which technique is used to identify autoantibodies? It's a very simple question, but what they have done in the option is they have kept it as direct immunofluorescence and indirect immunofluorescence. And this is for the serum antibodies. And ELISA, yes, this is not a technique, right? I mean, for detection of autoantibodies, we can give the exact titers of autoantibodies by using that technique. And FISH is, that it is mainly for your chromosomal related studies, right? Cytogenetic, you want to see some translocations, fusion, all those things you can do with fluorescent in situ hybridization. Now, if you want to detect the autoantibodies, okay, you definitely have to go for immunofluorescence. The antigens are best detected by using direct immunofluorescence, whereas the antibodies are best detected by using indirect immunofluorescence. Okay, if immunofluorescence is the only option, then definitely immunofluorescence is the only choice. But if they give you direct and indirect, indirect is going to be more sensitive and specific, okay, to pick up even the smallest concentration of the antibodies, and that's how the indirect immunofluorescence will become the answer in this case. So what is a fixative of choice in case of immunofluorescence? Again, there can be a lot of questions. Do you use any fixative when you want to perform immunofluorescence, especially the tissue immunofluorescence? If we are talking about the kidney as well as the skin, you don't use any fixative. You have to put the tissue in normal saline. This is very, very important. And you can use a transport media which is called as Michel's media. Okay, and then what are the patterns? I will be showing in the next slides. Okay, especially for SLE, you have different patterns of immunofluorescence. For tissue, then you have linear pattern and granular pattern of immunofluorescence. Okay, then IHC is different from immunofluorescence, which you perform on tissues which are fixed with the formalin, okay, as well as they are embedded with paraffin. So that is nothing but immunohistochemistry, and definitely you can use the 10% neutral buffered formalin fixed specimens for immunohistochemistry, whereas you don't use any fixative for immunofluorescence. Please remember this. Again, it's a very important question. Okay. Moving on to the next. Now we are switching on to hematology. A vegan patient with MCV, that is 110 femtoliter and hemoglobin of 10 gram percent. What is the most likely diagnosis? So MCV indicates here that it is already more than 100, right? 110 femtoliter, HB is low. You are under the impression it's vegan. So the moment you see these keywords, you are under the impression that you are dealing with macrocytic anemia, right? So look at the options. It's very easy. Iron deficiency anemia. Do we see MCV of 110 femtoliter? Normal MCV is how much? 80 to 100 femtoliters, right? Iron deficiency meaning microcytic hypochromic, and you expect MCV to be low in this case. Very, very important. What happens to aplastic anemia? Mostly it remains normocytic, normochromic, so you don't get to see this macrocytic picture. Megaloblastic anemia still possible. Thalassemia, again MCV is low. Very, very important, because iron deficiency anemia and thalassemia are important differential diagnosis of microcytic hypochromic anemia. anemia. So in this way, it's very easy to crack the answer here as megaloblastic anemia. What else can be asked in megaloblastic anemia? It can be an image-based, question wherein a hypersegmented neutrophil is given. What do you mean by hypersegmented neutrophil? A neutrophil with more than 5 lobes. So if you find a single neutrophil with 6 lobes, as you can see here, is a hypersegmented neutrophil, or if the neutrophil has got 5 lobes and such neutrophils are 5% above 5% in the peripheral smear, then you are calling it as hypersegmented neutrophils. Okay, macroovalocytes, as we already discussed, that is present. Cabot ring, which is actually derived from the microtubule, can also be present. Howell Jolly bodies, very, very important. These are nothing but the nuclear remnants. Okay, Howell Jolly bodies are the nuclear remnants, which are again seen in case of megaloblastic anemia. Basophilic stippling is all, it's a RNA remnant which can be seen as a basophilic stippling, and reduced reticulocyte count is also a feature of megaloblastic anemia. If you see a bone marrow, then what you can see is the erythroblast with what you call as checkerboard chromatin, or an open kind of chromatin which is large in size, which we call as megaloblast. Okay, megaloblasts are present. Then we have giant myelocytes as well as metamyelocytes in case of bone marrow. So these are the important things that you need to know. And most important is if they are giving you MCV, okay, MCV more than 100, you have to go to macrocytic anemia and then dig on what are the different causes of macrocytic anemia. Most importantly, it is B12 deficiency and folate deficiency. So try to see whether there is any cause which is related to it. Now in this case, it was pure vegan, which was already given in this case, right? And also you have to know that all macrocytic anemias are not megaloblastic anemias. There are non-megaloblastic macrocytic anemia. Simple: alcoholism, hypothyroidism, liver disease, all these are examples of non-megaloblastic macrocytic anemia. Okay. Now, moving on to which of the following is true regarding sickle cell anemia. This is a tricky kind of question, but you need to be little patient while analyzing such questions. Okay, sometimes it becomes so clumsy in the brain that no, I don't want to attempt this. But if you give some time, okay, then definitely you can attempt such questions, right? So what are the points which have been asked here? Is one is osmotic fragility. The second thing is mechanical fragility. What you are more familiar with probably is osmotic fragility, right? So because you would have already studied that osmotic fragility is high in which condition? You know that which hemolytic anemia where you have high osmotic fragility. What is the answer? The answer is hereditary spherocytosis, right? So in hereditary spherocytosis, you already know that the osmotic fragility is high, and in conditions like sickle cell anemia and thalassemia, okay, so osmotic fragility is low. So this you are already aware of, right? These spirocytes cannot accommodate, right, much of this hypotonic saline, and they become ruptured. So they are highly, the osmotic fragility is high, whereas sickle cell anemia and thalassemia, okay, they have low osmotic fragility. So you are done with one thing, that definitely there is low osmotic fragility. So you have to choose between two now. You have low osmotic fragility here, low osmotic fragility here. Next is whether they have low mechanical fragility or high mechanical fragility. There is definitely, because of the precipitation of abnormal hemoglobin, there has to be, they cannot actually go through like how the biconcave RBCs pass through the smaller and smaller blood vessels. They can't go through. That's why there is vaso-occlusive crisis and the other crisis with ischemic crisis which happen in case of sickle cell anemia. That's why definitely they have got high mechanical fragility. So if you think with little patience and apply your knowledge, you are definitely able to solve such questions. That is, the answer is high mechanical fragility and low osmotic fragility will be the answer. Okay, so this is how you can solve such questions. Now, in detail about sickle cell anemia, you know that there is point mutation at 6th position of beta globin gene, and remember that valine is waste, so that replaces the position of glutamic acid in case of sickle cell anemia. So there is reduced solubility as there is polymerization under deoxygenated state of HBS and formation of gel or tactoid. Okay. Now, Once, because they are, they can't go through the smaller vessels, there is microvascular occlusion resulting in ischemia and infarction. There is intravascular hemolysis as well as extravascular hemolysis. Sickle cell anemia can also be an image-based question wherein history says there is crew cut or hair on end appearance on the X-ray in a child or an adult, and then the smear is given to you. You have to immediately pick up this cell. That is nothing but sickle cell. Very, very important. Variable amount of, what are these cells? What are these cells? These are nucleated RBCs. They are very important characteristic feature of hemolytic anemia. See, please, you have to pick up such things. That is sickle cells, you have nucleated RBCs, you are dealing with hemolytic anemia. There is a leading history, crew cut or hair on end appearance. Yes, you are dealing with sickle cell anemia. One of the important complications that you have to remember here is autosplenectomy. It is said that thalassemia can give rise to massive splenomegaly in many cases, whereas sickle cell anemia gives rise to most of the times autosplenectomy when it is severe. Okay, and aplastic crisis in this case is associated with parvovirus B19 infection. How about this image? So this I have explained. What about this image? Any answer? Any answer? What is this? These are, as soon as you look into this image, you see that it is not stained, right? Unstained. And you can see that lot of sickle cells when compared to this image, they are highlighted or they are present. They are easily appreciated in this case. This is nothing but, yeah, very good, Rakshit. It is sickled RBCs. The answer is sickling test. Yeah, this is sickling test. What is the reagent used? All of you know that it is sodium beta bisulfite. It takes the oxygen so that these cells are deprived of the oxygen, and that's why naturally you will not see so many sickled RBCs and a routine peripheral smear. If you perform this test, yes, you will be able to easily see a lot of sickle cells. So this can also be asked as an image based question. That is nothing but sickling test, right? Moving on to the next question, which says low serum transferrin saturation levels is seen in which condition? Many of the students get confused when the question comes on these iron profiles. It's very, very important to remember iron. Then we have serum ferritin, okay, serum ferritin, we have serum iron, then we have transferrin, and last is TIBC. Okay, these four things, whenever the question comes based on this, somehow, even if you have studied well, you get confused. If your concepts are not clear, then yes, you will go confused and you will lose the area where you can actually score the marks easily, right? So remember one funda here, which is very, very important. Serum ferritin is inversely proportional to TIBC, okay, and serum iron is directly proportional to transferrin saturation, okay. So now a condition what is asked is low serum transferrin saturation level is seen in which condition, okay. Is it seen in iron deficiency anemia? Is it seen in hemochromatosis, hemosidrosis, pernicious anemia? Pernicious anemia is actually, it results in B12 deficiency. It's autoimmune condition. We are not actually bothered about iron in this particular case. So, we will easily exclude this. Hemosidrosis and hemochromatosis. They have given a pretty easy options where in both the situations you have iron overload, right? So, you have to only bother about there is increased serum ferritin and nothing else. Why we will talk about transferrin saturation. Only in this condition you have low serum iron. Very, very important. Iron deficiency anemia, naturally serum iron is low and hence the saturation, that is transferrin saturation, is also low. That's how you can easily solve this question. Okay. So iron deficiency anemia is the answer for this. So this funda you have to always remember. Serum iron is directly proportional to transferrin saturation. Ferritin levels are inversely proportional to total iron binding capacity. Right. So with that, basis in your mind, let's now try to analyze all this. So I told you in iron deficiency anemia, just remember one thing, that serum, everything is low except for TIBC. TIBC is high and see here serum ferritin is low. Okay, so just imprint in your minds that serum ferritin is low and TIBC is raised. Okay, they are inversely proportional in case of iron deficiency anemia. Thalassemia, nothing much to think. Here ferritin is more only. Many a times even there is iron overload, right? Serum ferritin is more, so TIBC is low. Sideroblastic anemia also, everything, see here, everything you can see that it is more only, right? It is not here. Actually, It can be normal, it can be low also at times in case of sideroblastic anemia. Now, if you go to anemia of chronic disease, this is something very, very important. In case of anemia of chronic disease, what happens is there is lot of transferrin, okay, but it is not available for RBCs. So that's how RBCs look microcytic hypochromic, okay. So what happens is there is lot of ferritin, okay. So in ferritin levels are increased, but TIBC is low. Even here it is low, okay. Remember this. Even in these conditions, it is low. For TIBC, there is only one condition where it is increased is iron deficiency anemia. In rest, all the conditions you can see that it is low. It is very, very important because many questions are framed with these iron profiles, ferritin levels, transferrin saturation, and total iron binding capacity. Next, moving on to the other, it's a kind of hypothetical question. Blue color vacutainer for plasma glucose estimation has which anticoagulant? Now, if I ask any student here, is it the blue color vacutainer which is used for plasma glucose estimation? What is used for plasma glucose estimation? What color vacutainer? Do we have any answer? Okay, for plasma glucose, it is C, very good. Sodium fluoride, it's Renal. Yeah, sodium fluoride, it also has got potassium oxalate. So that is used for plasma glucose estimation, right? Now, but the question says blue color vacutainer. If you ignore this part, luckily, probably in the upcoming exam, you don't get such questions. Now, if we analyze it simply, blue color vacutainer has what anticoagulant? Definitely it is trisodium citrate, right? It is 3.2 to 3.8% sodium citrate, which is for the blue color vacutainer is what we have studied. So this will be the answer. We don't know what the intern or whoever wants to use it for whatever the test. Then it's going to be wrong, right? Blue color vacutainer has trisodium citrate and it should be used for what? It has to be used for coagulation studies, right? So that will be the right option here. Then heparin. Heparin is the green topped vacutainer. Sodium fluoride you all have answered. That is even INI-CET has answered it as grey color vacutainer. Then EDTA, you know that it is for all the CBCs. Routine blood test, complete blood count, we use EDTA. That is lavender topped vacutainer. So you can't miss this topic, that is vacutainers, and never go confused because it's going to be simple, right, to answer if you know it thoroughly. So these are all the different vacutainers that have discussed already. And remember that this red topped vacutainer does not have any anticoagulant. Very, very important. It will give you serum, and if you want to do some studies with respect to serum, you can use this red topped vacutainer sample, okay. Now, order of draw is something which is again asked in one of the examinations. Remember this, it's not stopping at vacutainer. What is the anticoagulant used? What are the different tests which are done with that vacutainer? But now the question is at the level of order of draw, okay. So for this, there is a mnemonic. Due to contamination, blue river goes little grey. River, blue meaning something it is pure, grey because it is contamination, so it is impure. So that's the understanding of this mnemonic, right? So contamination is actually first you have to send the sample to microbiology. Then you have to use this blue top vacutainer where you have sodium citrate. Okay, R stands for red here, okay, where you don't have any anticoagulant, you are doing some serum studies. And this goes is for green, okay, this is very, very important. First you have this green and then gold and then a little for lavender. Okay, lavender that contains EDTA, and lastly grey. At least try to remember grey is in the end, and just before grey you have lavender color. So that's the order of drawing the blood for different tests. This is very, very important, right? Moving on to the next question. This is 35-year-old male patient came with the complaints of fatigue and weakness. So we have a mid-year patient, 35-year-old. Peripheral smear is given to you. And you have to tell the most likely genetic change which is associated with this particular disease. Very, very easy. The moment you see this cell, okay, what you can see here, what is this structure? This is nothing but OR rod which is given here, okay. So this OR rod will tell you that you are actually looking at a myeloblast. Very, very important. Now, what are the options? 922. Are you seeing it in acute myeloid leukemia? You have come to the conclusion that you are seeing myeloblast and probably I am dealing with acute myeloid leukemia. Do you see 922? That is nothing but a Philadelphia chromosome. In case of AML, no, because it is seen in CML. Okay. 1517, that is PML rara, which is seen in APML, okay, that is acute promyelocytic leukemia or M3 type of AML, okay. 1114, where do you see 1114? That is in case of mantle cell lymphoma. And where do you see 1418? Again, any answers? What is the translocation? This 1418 is seen in which type of lymphoma? Anyone remembers? These are all very, very important. It should be at the tips of your tongue by now. 1418 is for follicular lymphoma. It's like number games. You have to actually play with your friends, right? Ask one number, that is one translocation, then they ask. You can play a lot of games with these translocations, especially in non-Hodgkin lymphoma, okay? Keep on doing that so that you don't forget these important translocations. So what is the answer, students? Now it is very, very easy. That is 1517, okay? Though they have not given you a phagoid cell, actually this particular blast should have filled with lot of rods. That is nothing but phagoid cells. Those phagoid cells are characteristic of acute promyelocytic leukemia, but then it's okay. The only option is related to acute myeloid leukemia. Here is 1517, that is PML rara, which is acute promyelocytic leukemia, right? So this is how it should have been seen. This is a very classical appearance, okay? You can see here, this is a blast. These are called as atypical promyelocytes. They have got lot of bundles of rods within the cytoplasm. Everywhere, if you see here carefully, have bundles of rods in the cytoplasm. They are nothing but the phagoid cells, okay? You even have this indented, which is called as apple core kind of nucleus, which is present in case of acute promyelocytic leukemia, and most common translocation is translocation 1517. Remember all this. All those are very, very important. I've many times told between the, the differences between the myeloblast and lymphoblast. But what is very important to remember is myeloblast is larger in size, whereas lymphoblasts are slightly smaller when compared to that of myeloblasts, okay. Prominence of nucleoli. If you see many number of nucleoli, okay, multiple nucleoli, 1 to 3 prominent nucleoli are a feature in case of myeloblast. That is not a feature of lymphoblast. Usually you don't see prominent nucleoli in case of lymphoblast. But what will, for an undergraduate who is preparing for a PG, what is actually more, which gives a highest clue that I am a myeloblast or lymphoblast is presence of OR rod, okay. If they are asking you a question on myeloblast, OR rod is always present in the cytoplasm, so that you will be able to see that OR rod and then able to make the diagnosis of, myeloblast and call it as acute myeloid leukemia. Students, what is the percentage of blasts that should be present? What are the percentage of blasts to call it as acute myeloid leukemia or acute lymphoblastic leukemia? What is the percentage? It should be above 20%. Very, very important. Okay, it should be above 20%. That's the cutoff. So that's for my acute myeloid leukemia or acute lymphoblastic leukemia. So remember that OR rod. OR rod is a very important thing in case of myeloblast, which is not seen in lymphoblast. What is the special stain? Again, MPU, very, very important. Myeloperoxidase positivity, which is seen in myeloblast, whereas lymphoblast, what is the special stain used, which gives block-like positivity? That is per-iodic acid shift or PAS. Okay. So remember these soft points so that it is very easy that as soon as you see the image, okay, you are able to make the diagnosis. Which of the following marker is specific or markers of seminoma? Okay, multiple choice has been given and you can choose many answers in this. PLAP, what is PLAP? Placental alkaline phosphatase. Yes, you know that it is a marker of germ cell tumor in general and also for seminoma. You will say yes. OC3, NANOG, SAL4. If they are in the option, you know that yes, they are the markers of germ cell tumor. KIT, never forget games. Okay, that G for germ cell tumor, in that most important is seminoma and dysgerminoma. Okay, you will always see this KIT related question in your upcoming exams, and then KIT you should be able to remember GIST, germ cell tumor, mastocytosis and sinonasal NK cell lymphoma. That's a must. Okay. HCG, this is little confusing here. You know that HCG is a marker of which germ cell tumor? That is choriocarcinoma. Okay. Choriocarcinoma. Though you can see this choriocarcinomatous component in many of the germ cell tumors, mainly even in seminoma, okay, they can show this choriocarcinomatous component. But yes, this is not a marker per se for seminoma. So what are the markers for seminoma is only PLAP, OC3 and KIT. So the option here, the right answer will be here A, B, C only. Okay, if it is a germ cell tumor in general, then definitely all four will be the correct option. But for seminoma, HCG is not a specific, HCG. IHC marker to be used. So again, this table is going to be very, very important for you. So please look at this table every now and then so that you don't forget the markers. Okay, KIT has to be imprinted in your mind that it is for seminoma, OCT4, even SAL, placental alkaline phosphatase, everything. I have told you HCG minus or plus depending on whether that choriocarcinoma component is present in the seminoma or no. And if it is too much, then it becomes a part of mixed germ cell tumor, right? What is the special stain used? Even that can be asked, that is PAS in case of seminoma. In case of embryonal carcinoma, remember that cytokeratin is also positive and CD30 is positive in embryonal carcinoma. What is the marker for alpha fetoprotein? What is the marker of, yolk sac tumor is alpha fetoprotein. Again, this is a very important thing. Marker of yolk sac tumor is alpha fetoprotein. This is not seen in any other germ cell tumor. So, you need to remember. And hyaline globules will be positive for PAS in case of yolk sac tumor. Remember this, hyaline globules are positive for PAS. So, for choriocarcinoma, what is the marker we have is HCG. Okay. So, even variable CK positivity can also be seen. But remember that this HCG is for choriocarcinoma. So, there can be questions again from this particular concept, that is IHC in case of testicular germ cell tumors. So, you have to be really thorough about this, right? So, just to revise, this is the gross specimen, the lobulated typical gross appearance of the seminoma that you have to remember. It's very, very important. And then you have these germ cells, right? These are all the malignant germ cells or the seminomatous cells. What is very typical of seminoma is sprinkling of lymphocytes. This can even be an image-based question because it's not very difficult to diagnose, right? You have those germ cells, there is a septum which is infiltrated by a lot of lymphocytes. There can be large areas of hemorrhage and necrosis in these tumors. Okay, what is the most common type in the testicular tumors? That is germ cell tumor. Okay, what is the most common germ cell tumor in adults? That is seminoma. What is the most common germ cell tumor in children? What is the answer here? It is a yolk sac tumor. Okay, so that way you can answer further questions related to this topic. Now, which of the following is the most important prognostic factor for carcinoma breast? Look at the options. All are important. Now, we have just studied prognostic factors for breast carcinoma, but the question says most important prognostic factor. Now, the problem comes. How to approach this question? Lymph node, the involvement, distant metastasis, is it size of the tumor or hormone receptor? And you know that everything, yes, they are prognostic factors. But if you understand the core concept of neoplasia, what are the hallmark? What is the hallmark for malignancy? For any malignant tumor, the hallmark feature is invasion and metastasis. So, the best option here will be the distant metastasis is the most important prognostic factor, followed by the lymph node involvement and then hormone receptor status and size, etc. Okay. So, the regional lymph node involvement, this is given in Robbins, is direct from Robbins, regional lymph node involvement and distant metastasis. They are powerful prognostic factors. But the question is only one if you have to choose, and most important you have to choose. The answer will be distant metastasis is the most important or the powerful prognostic factor. Okay. The others are tumor size, locally advanced tumor, lymphovascular invasion, the histologic type, grading, response to neoadjuvant therapy. All those are other important prognostic points. So, please remember this point. Now, they are not asking more on the morphology like fibroadenoma, infiltrating duct carcinoma, but it is on the molecular classification, number one. Then you have the luminal type A, B, right, and HER2 rich, basal type, triple negative, all those questions have been asked. And then you have questions on the prognosis of breast carcinoma and genetics, mainly the BRCA1 and BRCA2, BRCA1, BRCA2 related cancers. Okay, so that point you have to concentrate now. Moving on to again switching back to genetics. I have told you it's going to be potpourri, and we will switch back just to make comfortable ourselves with our thinking process. It should not be very programmed. It should not be very, very systematic, because in exams you will see mixture, and it's not only pathology. You will see microbiology, pharmacology, everything is mixed. So you have to do a kind of brain gym where you are able to switch from topic to topic easily. Now again, this question says 26-year-old female. There is a bleeding disorder. Moment you see this female and father and sister, are we thinking of some kind of X-linked, or are we talking of some other kind of disease, but they have already given. You need not think of what Mendelian inheritance is there, because they have told it is autosomal dominant. Okay. Now the job is only to pick up which is autosomal dominant. The very first question I have told you, you can't escape from the questions on autosomal dominant, recessive, X-linked dominant, X-linked recessive. It has to be memorized, it has to be remembered, seen every now and then, so that you don't miss such questions. Now you know hemophilia A, is it autosomal dominant? No. What is the mode of inheritance of hemophilia A? It is X-linked recessive. Christmas disease, same thing. Then factor 10 deficiency. Now only von Willebrand disease in this particular case is autosomal dominant in nature. Easy. So it becomes very easy when you are thorough with, when you are very good at picking the clues and putting in the options and exclude which is not fitting best into that particular question, right? Next is, which of the following is not a feature of Down syndrome? You will have questions on usually the Down syndrome, Turner syndrome, Klinefelter syndrome, right? So now the question is on Down syndrome, which is not a feature. Caudal regression, short stature, hypothyroidism, conductive hearing loss. You have studied about all this and you have no clue about caudal regression, where there is premature termination of the spinal cord. And that's why probably you will mark this as a correct, and that's the correct answer. Okay. So there can be options like simian crease, umbilical hernia, predisposition to leukemia. Very, very important point in case of Down syndrome, right? So in trisomy 21, these children are prone to which type of acute myeloid leukemia? Very, very important question. They have a high risk to progress towards acute myeloid leukemia. Which type? Any answers? I'll wait till I continue, complete this particular slide for answer. Which type of leukemia is commonly seen in children with Down syndrome? There is a high risk. Okay, they have a high risk for Alzheimer's disease as well as, very good, I got an answer. Thank you, Rakshit. That is AML M7. So Down syndrome patients have got highest risk for AML M7. Very, very important question again. Okay. Now, there can be options like predisposition to leukemia, intestinal stenosis, congenital heart defects. Okay, so all those things you need to look carefully and remember what is actually seen in Down syndrome and what is not seen in Down syndrome. This is the most common chromosomal disorder, most common cause of mental retardation. Very, very important. And remember that what leads to trisomy. This is something which is very important. Meiotic disjunction. Okay, so this meiotic disjunction leads to trisomy in 95% of the cases, followed by Robertsonian translocation, and least common it is mosaicism. So this question can also be asked, what is the cause of trisomy in this? Most common. Okay, so that is meiotic non-disjunction. Then we have Robertsonian translocation, and last we have mosaicism. And as I already told you, there is increased risk of Alzheimer's disease and M7 AML. They are specifically prone for. So remember all these things related to Down syndrome. And regarding Klinefelters and Turners, this is very, very important from chromosomal disorders. You have to remember, okay, you know that Klinefelters is 47XXY, and in one of the exams even the karyotype is given 45XXY. You have to first tell that it is Klinefelter syndrome and then look for what are the key clinical features which are present and then exclude the options. Okay, so that's what the question was. Infertility, then failure of secondary sexual character development, small atrophic testes, tall stature, small penis. So there are gynecomastia. Many of these are given in the options actually in that question. Okay. Associated risk is what I want to emphasize here, because many a times you know the major features, you would have seen the patient, right? But then the associated risk, because we will not see them so commonly, it is difficult to, remember them. So you need to remember that mitral valve prolapse, the atrial and ventricular septal defect, extragonadal germ cell tumors are commonly seen in patients with, the Klinefelter syndrome. Whereas with Turner syndrome, this web neck is given in many of the questions. By the moment you see this web neck, short stature, yes, streak ovaries is what you expect, and yes, you are thinking about Turner syndrome. That is X0. Okay, so that's what you need to remember. And the additional characteristic feature, what is most important here is coactation of the aorta, aortic regurgitation, gonadoblastoma. All those things are very, very important. And if a question comes on bar body, XXY, naturally you have one X extra, you have one bar body, you will see definitely. Whereas X0, no, you will not see any bar body. Okay, so that's what, these are the different questions that you can expect in Klinefelter and Turner. I request all of you to thoroughly go through all the clinical features, the associated factors, and associated the chromosomal anomalies in these particular cases. Okay. Now again switching to immunohistochemistry question. Which of the following stains cause brown color to HER2 immunostain given below? All these days they were busy asking the IHC markers, right? Now they want to test you one level more. So now they are asking in detail if you know the technique of immunohistochemistry or no. So that's the purpose. Now it imparts brown color. Moment you see this brown color, and here you are able to see certain cells. Okay, I will enlarge this. You can see that this is nothing but the intense membranous, complete membranous, strong positivity, and here you have the nucleus. If you can see carefully, pale blue nucleus is visible. Now what is the question? Why there is brown color? Okay, so chromogen actually gives this color in case of immunohistochemistry, and different chromogens are used depending on different enzymes which are being used. What is the principle of immunohistochemistry? That you are first supposed to know. So you have a tissue sample, then you have primary antibody to which the secondary antibody binds, and that is tagged with the enzyme. Okay, those enzymes can be, what is HRP? What is the full form of HRP? That is horseradish peroxidase and alkaline phosphatase. Okay, this alkaline, either you can use the enzyme alkaline phosphatase or you can use this horseradish peroxidase. Okay, then they are tagged with a chromogen. Okay, so that chromogen, depending on what enzyme and chromogen you have used, you will get a particular color. So if you use this horseradish peroxidase, very important, and you will get brown color because diaminobenzidine is a chromogen used there. Remember this, in brown color, DAB, just remember it as DAB. So DAB is the chromogen used. If you would use other things like carbazole, you have reddish color, then blue color because of TMB, and green color for imerol. Just forget about all those things, but yes, most important is DAB, and that is what is most commonly used. If you use alkaline phosphatase, many a times you can get reddish or pink color as an end result. There fast red or permanent red is used. It is very easy to remember because you have red and red here, right? But you remember that DAB is not used with alkaline phosphatase. DAB is used with horseradish peroxidase only, and that is the reason why you get brown color. So what is the answer for this question? DAB, diaminobenzidine. They have even given you the aminobenzidine, so that is not the correct answer. Diaminobenzidine or DAB is the chromogen used when you get brown color. And what is the enzyme there? So next time question can be on the enzyme. So what is the enzyme we talked about in conjunction with this chromogen, that is DAB? What is the enzyme? HRP, that is horseradish peroxidase. Remember, because next time the question can be on this enzyme, either HRP or on alkaline phosphatase, right? Okay, moving on to the next question. This is yet again one level interesting question, and this is a little brain teaser. Okay, in a patient with hepatitis B infection, HBsAg is non-reactive. They are telling that HBsAg is non-reactive, HBeAg is non-reactive, anti-HBm HBsAg antibody is non-reactive, then anti-HBs IgM is non-reactive. Oh, what is reactive then? Only one thing which is reactive is total anti-HBc is reactive, meaning IgM they have told it is negative, right? So how can total be positive? It is because of IgG which is positive, right? So antibodies are there which is of IgG nature, and they are against HBc. Rest all like HBs. What now? Let's try to analyze. Now HBsAg is negative, correct? So this is negative. HBeAg is negative. IgM is negative. Only total is positive, and anti-HBs antibody, which is again IgM in nature, is negative, right? When you look into such questions, first don't be panicked, just be calm and think what is there, and you can come to these questions later. Solve all your factual based questions or knowledge based questions, and then lastly come to such questions where you, with little patience, yes, you can definitely solve such problems. It is not difficult. Okay, sit calmly and just now let's try to analyze. HBsAg is positive, HBeAg is positive, and anti-HBc antibody IgM type is positive. So what is the scenario given now? If I give this scenario, what is the expected outcome in the patient? If you have HBsAg positive, HBeAg is positive, anti-HBc antibody is positive. Okay, now if this is the the set of diagnosis which is positive in one patient, we are probably thinking of acute hepatitis B. right? Now, if we think of the similar setting, HBsAg is positive. Now, HBeAg, then anti-HB antibodies. Instead of that, we have now antibodies, and anti-HBc antibodies are also positive, which are probably IgG, IgM, everything. IgG antibodies are now present. Now, we are dealing with a scenario that is chronic hepatitis B. So, our scenario is entirely different because HBsAg itself is negative. Okay, so forget about other things. Now, anti-HBsAg antibodies, if they are only present, nothing else is present, but only you have antibodies against HBsAg. What is the condition? It is because of vaccination. Okay, if you have received vaccination, then you have antibodies against HBsAg antigen. Now, apart from this anti-HBc antigen antibodies, if you have anti-HBc antibodies also, you have HBsAg antibodies, but you have antibodies against anti-HBc antibodies also together, then probably you are a healthy carrier. Okay, so that is how we interpret. Now, if we look into our scenario, which is everything is negative, only total, that is the total anti-HBc is positive. IgM negative, but probably because of IgG, total is coming as positive, right? Chronic HBV window period. Is it possible? In window period, what are we supposed to see? HBC, anti-HBC antibodies have to be present, which are of IgM type, right? That we expect. Even that is negative. So, this can't be the answer. Then chronic hepatitis B carrier. We told what is a carrier. So, even that is not fitting here. Post-vaccination status, you expected anti-HBsAg antibody to be positive. Even that is negative, right? So, with that condition also, even post-vaccination status, does not fulfill. What is only possible is remote infection with complete recovery will be the best possible option in this case. So, likewise, the questions cannot be, really tailored or standardized to a very typical setting. There can be some here and there, and where you have to really think and choose the best possible answer. Okay, why IgG against HPC is there is probably the patient had remote infection and probably he is recovering, and that recovery is complete, and that's why you have got only IgG antibodies against HPC, right? So, this is how you can solve some difficult questions. Moving on to the next question. 47-year-old male with 400 ml of urine in 24 hours. What is the question saying? That there is already oliguria, right? In 24 hours, there is only 400 ml of urine. On histology, they have given you more clues. Like there is RPGN with pauci-immune glomerulonephritis with crescents. Okay, rapidly progressive glomerulonephritis. That also they have told you. And it is pauci-immune in nature. You know that RPGN are how many times? How many types of RPGN are there? Any students? RPGN types. Rapidly progressive glomerulonephritis are of how many types? There are 3 types of RPGN. Okay, one is where the antibodies are against anti-glomerular basement membrane. The second one is immune complex, and lastly we have the pauci-immune. Pauci-immune meaning there is no immune complex deposition when you see the glomeruli under immunofluorescence. Yes, Manaswini, you got it right. There are 3 types of RPGN. Okay. So, it is already, the question says there is RPGN, it is pauci-immune in nature. So, naturally, you will not think of anti-GBM antibodies, which is seen in Goodpasture syndrome, and that is type 1 RPGN. ANCA antibodies will come back to it later. Anti-PLA2R antibodies. Can anybody tell me where do you see anti-PLA2R? Phospholipase A2 receptor. It's again very recent. Okay, nowadays we have lot of antibodies which are coming up for this particular entity. Can anyone tell me where do you see PLA2R antibodies? I'll wait for some time till I solve this. PLA2R antibodies are seen in which condition? Very important question. Okay. ANA. So, that's everybody's favorite SLE. Okay. Anti-nuclear antibodies are seen in SLE, and that is an example of immune complex pauci-immune glomerulonephritis and not the example of pauci-immune. So, what is left here is only ANCA, and that is the correct answer. Okay. Pauci-immune, it has got anti-neutrophil cytoplasmic antibodies, but when you see it under the immunofluorescence, you will not see any deposition in the glomeruli. That is the definition of pauci-immune glomerulonephritis. Now, anti-PLA2R antibodies, any answers? I am waiting for that answer. Okay. Now, moving ahead, that is P-ANCA and C-ANCA. ANCA, you know that there are 2 types, right? So, MPO-ANCA is nothing but P-ANCA, that is antibodies against myeloperoxidase, and if the antibodies are against that is proteinase 3, you call it as C-ANCA. Okay. So, P-ANCAs are usually seen in microscopic polyangiitis and eosinophilic granulomatosis with polyangiitis, which is called as Churg-Strauss syndrome before, and now we call this call this condition as eosinophilic granulomatosis. Vaginous granulomatosis is a typical example of C ANCA. Remember this, very, very important, right? Atypical ANCA, meaning ANCA is present, but the underlying conditions like vaginous, microscopic polyangiitis, Churg-Strauss, all those are not present, then you call the condition as atypical ANCA. Remember this. This can be seen in patients with ulcerative colitis, primary sclerosing cholangitis, and primary biliary cirrhosis. Remember this condition, very, very important. Now, this is what we already told, that there are 3 types of posse-immune glomerulonephritis. Remember this. This is very, very important. Posse-immune GN. Okay. So, here we see that the ANCA associated comes somewhere here, right? ANCA associated. We have the examples here, that is mainly the granulomatosis with polyangiitis. This is the new name. Remember this. This is very, very important. Vaginous granulomatosis is now called as granulomatosis with polyangiitis, and the next example is microscopic polyangiitis. All those things would result in crescentic glomerulonephritis. And why are the crescent formed? Crescents are formed because of proliferation of which epithelial cells? If I ask you a question whether it's parietal or visceral, which epithelial cell proliferation results in crescents? It is parietal cell. Okay, if visceral proliferates, we call it as pseudocrescents, which happens in collapsing FSGS. But parietal proliferates, it is a true crescent. And to call it as crescentic, the crescent should be more than or equal to 50%. If crescents are present, then it is said that more the number of crescents, the prognosis is going to be bad. Okay, so this is an example of linear deposit of IgG along the basement membrane. Observe this. This is very, very important. This is in immunofluorescence, and this is a classic example of anti-GBM nephritis. Remember this, very, very important. Anti-GBM nephritis. This can be present in isolation or a part of good pasture syndrome, where the patient presents with pulmonary hemorrhage along with the rapidly progressive glomerulonephritis, right? That's very important. Type 2, there are immune complex deposition, even SLE can be an example of this. And type 3, I told you, it is associated with ANCA, anti-neutrophil cytoplasmic antibodies. Look at the picture here. It's very beautiful crescent which can be seen with the silver stain, and there is proliferation of parietal epithelial cell. Okay, so there is proliferation of parietal epithelial cells, and they compress the underlying tuft. Remember this, very, very important image based question. I got the answer from Wondergape. Yeah, very nice. So the membranous nephropathy is associated with PLA2R. Students, please remember this, because the next time the question can be on immunofluorescence of membranous nephropathy, the granular IgG staining, or the light microscopy picture and the antibody is being asked. The anti-PLA2R antibodies is associated with membranous nephropathy. Right? So there can be different questions from this, even from good pasture syndrome, anti-GBM nephritis, the linear pattern that I showed you just now. Okay, so this is what I am predicting. So the next time you can have the membranous pattern here, like thickened glomerular basement membrane. This is the beaded kind of fine granular appearance. This is very beautiful here, fine granular appearance along the basement membrane for IgG. That is what you need to remember, and this is very, very typical of membranous glomerulonephritis. Where do you see tram track? So all those can be image based or just a one-liners where the knowledge based domain can be tested. Tram track appearance is because of the splitting of the glomerular basement membrane due to mesangial interposition that you see in case of MPGN. Where do you see full house? I leave it to students. This is on immunofluorescence, where you get positive for IgM, IgA, IgG, C3 and C1q. Okay, that is called as full house pattern, which is typically seen in which condition? Wire loop kind of appearance in light microscopy. Okay, is seen in which condition? Subepithelial lumpy, bumpy, hump-like deposits are seen in the typical electron microscopy findings. They are seen in post-infectious glomerulonephritis and KW nodules. Come on students, it's very, very easy. KW nodules, Kimmelstein-Wilson nodules are seen in case of diabetic nephropathy. So, I'll leave this full house as well as wire loop for students. Let me again come back to that question when somebody answers. Okay. Next, moving on to the question, that is, what is the stain used for cervical smear? Okay, the moment you see the smear, don't get puzzled. Okay, they have given you one more clue that there is a cervical smear. As an undergraduate, you might not have seen, this kind of smear because you are not involved in routine reporting. Yes, Manaswini, I got the answer. Very good. Full house pattern is seen in SLE. And how about wire loop? Wire loop lesions are seen in which condition? Somebody answer, please. So, the question already says that there is cervical smear. Okay, liquid based cytology preparation is given. Probably that was not told in the question, but cervical smear is told, and something circular. On the slide you have the circular bluish material which is covered with the cover slip. Okay, so whatever it is, cervical smear, what is the stain to be used? Remember this. That is pap stain. Only papinicular stain to be used. Whatever it is, you are taking a smear from the cervix. Whether you do a conventional smear, you do a liquid based cytology by using thin prep, sure path, whatever it is, you have to do a pap stain only, which was developed by George Papanicolaou. Remember this, father of cytology, George Papanicolaou deduced this technique, and you are using that technique only. Whatever, you are taking the same material. Only thing is the presentation is different, right? I will show you the presentation of conventional smear. So HND is what? It's a universal histopathologic stain which is used everywhere. H stands for hematoxylin, E for eosin. Papanicolaou is whatever I have told you already. Congruent. Now please don't say that congruent, I don't know. It is for amyloid. It's a specific stain for amyloid deposits. GIMSA, where do you use GIMSA? For demonstration of Helicobacter pylori. It is one of the Romanowski stains. Okay, remember that. And now, so this is how the conventional smear is presented, right? This after you take the smear from the transformation zone, spread it on a slide, then fix it with 95% alcohol, ethanol. Okay, remember that. And then this is how you prepare the conventional smear. Whereas liquid-based cytology, it is presented in a neat way. Okay, remember that the area what pathologist has to say see is very less. There is no dirty background in that, and it looks very clean in the takes the shape, circular shape. That's where we examine. But what is the stain used? What is the stain used? Pap stain. Okay, papinicular stain is used. Remember this, very, very important. What is the reporting system used? This can be a question again, because they have now moved to liquid-based cytology. Next is reporting system. So what is the reporting system used in pap smear reporting or cervical cytology reporting? Remember this, Bethesda system. Okay, so Bethesda system of reporting is used. Liquid-based cytology, I have already told you, it can be thin prep or sure path. What is the adequacy? You should be able to see in conventional smear 8,000 to 12,000 well preserved squamous cells, and LBC you can see up to 5,000 cells. Okay, if you see 5,000 well preserved squamous cells, then it is said that your smear is adequate. Okay, so that's about LBC. And pap smear. So don't get confused. If they give you conventional also, answer is the same. If you give LBC also, if they are asking you the stain, it has to be pap stain only. Okay. So the next question is, patient is having there is a history of tuberculosis. They have directly given you, so no need to think. And image is leading, right? You are going to see a Langhans type of giant cell here, and you are seeing a well-formed granuloma with epithelioid histiocytes. So this is, all those are epithelioid histiocytes. Okay, slipper-shaped nucleus is also there. You have got giant cell here, and one more is Langhans type of giant cell. If you have so many resources, it's very easy to crack the answer. But what they have asked, have they asked you the what kind, whether there is granuloma? No, they have not asked you the granuloma. They have told which of the following cytokine induces the following pathognomonic phenomena. Firstly, you have to tell that there is granuloma. TB is there. So what you can expect? Caseous necrosis, Langhans type of giant cells, epithelioid cell, granuloma. Okay, so that is already done. Now next is more into your, digging more into your analysis part, not just the knowledge part. You have analyzed that this is granuloma and how this granuloma is formed. That is pathogenesis of very good Langhans type of giant cells. I got the answer. Nice. This is Langhans type of giant cells. And now, what was the reason for this granuloma formation is what they are asking. Is it complement 5A, interferon gamma, histamine, bradykinin? If you have thoroughly studied the pathogenesis of granuloma formation in inflammation chapter, or if you have thoroughly studied the pathogenesis of type 4 hypersensitivity, you will definitely know the answer, right? Initially, macrophage will try to engulf those Mycobacterium tuberculosis. They failed to do that. There is failure of phagolysosome formation. 3 weeks they'll wait, try to fight. It won't happen. Next, what they will do? They'll call helper T cells. What type of help? Th1 helper T cells are, CD4 type cells are called for their help. Now, what does it do? While calling for the help, how do they call? Do they have any number? Yes, they dial interleukin 12, meaning they just send interleukin 12 signals so that there is more and more proliferation or differentiation of CD4 CD4 Th1 type of helper cells, so that they release more and more of interferon gamma. With the help of this interferon gamma, this ordinary macrophage will convert into what is known as epithelioid histiocytes. Very, very important. And the aggregate of that epithelioid histiocyte is nothing but granuloma formation. Remember this, and by forming the giant cells, they become more and more powerful. This is the story of granuloma formation, and interferon gamma is a major cytokine which plays a very important role. Granuloma, interferon gamma. Granuloma, interferon gamma. So this way you can remember this. Very, very important. So never forget this. Okay, pathomechanism of granuloma formation. What else they can give you in future is caseous necrosis. Please try to appreciate this caseous necrosis where you don't see any nuclear remnant, like amorphous pink eosinophilic material, and surrounding which you will see multiple granulomas. This appreciation of caseous necrosis is very, very important in the image, because most common causes tuberculosis. Yes, you can see caseous necrosis in other causes like syphilis, histoplasmosis, coccidioidomycosis, etc. Okay, so they can give you image based question where you have granuloma, caseous necrosis, they then dig into pathomechanism. Okay, even that can happen. Remember, interferon gamma is for granuloma. Okay, so this is the journey of granuloma formation, and we have a lot of giant cells in pathology. So any of those, even totem type of giant cells, xanthoma, tumor giant cells, in case of any malignant tumor, right? So such questions can also be asked. The cytokines, I'll come back to this later. Because there are many questions on cytokines in one of the INI-CET exams, right? Now, moving on to the next set. Which of the following are features of necrosis? It's a very, very easy question. Disrupted cell membrane. Necrosis is a mode of cell death, right? So, there will be disrupted cell membrane. There is cellular swelling. It induces inflammation. Everything is true. What is not true is necrosis is always pathological. Always pathological. Remember this. Necrosis is always pathological, whereas apoptosis can be both physiological as well as pathological. Okay, that's why it's a very easy. I know which of the following are features of necrosis. Disrupted cell membrane, it induces inflammation and cellular swelling. Why it induces inflammation? Because the cellular contents leak out, they come out, right? So that content can, invoke the response of neutrophils and induce inflammation. Now, differences between necrosis and apoptosis is something basic, and there you can't go wrong. Okay, no excuses if you go wrong in this, because you have to remember and understand the concept, right? So, necrosis is always pathologic. The cellular contents leak out, cell size get increased. What are the nuclear changes? So, next you can anticipate question on this nuclear changes. Very, very important. That is, if this is a normal cell, if the nucleus shrinks in size, what do you call that as? Pycnosis. Very, very important. You call this as pycnosis. Okay. If the pycnotic nuclei breaks, okay, then you call this as karyorrhexis, breaking of pycnotic nuclei, right? And if it simply dissolves, okay, dilutes into the cytoplasm, which is dying, then you call this as karyolysis. So all those nuclear changes occur in necrosis. In apoptotic bodies, apoptosis, it simply forms the apoptotic bodies, and then only there is chromatin condensation. And remember that necrosis occurs usually in groups, like many cells undergo. Single cell apoptosis can also happen. Okay, and shrinkage of cell is very important. The contents do not leak out. Apoptosis, no, it never induces inflammation. There is no much of time. As soon as the apoptotic bodies are formed, they get within minutes or within seconds, they are getting cleared by the macrophages. They don't send signals to anyone so that there is inflammation which is induced, right? So all those are important differences that you need to remember, and be thorough with the appearance. What is this? So this is the coagulative necrosis in spleen. This is a gangrene type of necrosis. This is very typical. Now, instead of microscopy, a question on TB can even have what? There can be gross, this is a lymph node. The multiple matted lymph nodes with cheesy white amorphous deposits, which can be seen in the cut section of lymph node. That is nothing but caseous necrosis. The moment you see this, yes, this is caseous necrosis. In India, number 1, number 2, number 3, whatever the cause, it is tuberculosis. Okay, so that's how you can come to the conclusion. Now, fat necrosis, commonly seen in breast and pancreas as well as the omental fat. And fibrinoid necrosis is something the student does not remember so easily. Okay, so it is seen in vasculitis, malignant hypertension, and in rheumatic heart disease, the pathognomonic lesion. What is a pathognomonic lesion? That is Aschoff body, right? So there you usually see this particular body. Now, this is about the morphologic changes I have already told you. In apoptosis, you have the cellular shrinkage, chromatin condensation, cytoplasmic bleps, and apoptotic bodies. Now, what you have to remember more than this is, if there is a question on polyacrylamide gel electrophoresis, this is important. Smear pattern, okay? The smear pattern is seen in case of necrosis. If you get this pattern in case of necrosis, because of internucleosomal cleavage, what you get is ladder pattern in case of apoptosis. So, ladder pattern in case of apoptosis and smear pattern in case of necrosis in case of if you do a page electrophoresis, that is polyacrylamide gel electrophoresis. Remember this, very, very important. The other important question is marker of apoptosis. Do we have any answer? I'll wait for this answer. I want markers of apoptosis. Okay, I'll come back to this as soon as I see the answer. This is not a tough question, very easy question. Just try to remember important marker of apoptosis. Okay, which of the following is an anti-apoptotic factor here? Okay, very easy question. Okay, moment I say anti-apoptotic, what you have to remember is BCL family is what you want to expect, right? So, are we seeing CL in any of these options given? Yes, we are seeing options here, MCL, right? CL is not seen in any BAC, BAD, BID, Puma, Noxa, all those are pro-apoptotic in nature. So, what is the correct answer here is MCL1. What are the other anti-apoptotic factors? Very good, I got this MCL1 is a correct Nafis. And C, yeah, it's answered by Aniket also, very nice. MCL1, apart this CL, this is important clue, okay, anti-apoptotic. I'll tell you why. BCL family is anti-apoptotic in nature, BCL2 family of proteins, BCL2, BCLXL, even that is anti-apoptotic in nature, and MCL1 is also anti-apoptotic in nature. So, if you know this CL funda for anti-apoptotic nature of proteins, it's very easy to crack this, and rest all are pro-apoptotic in nature. In apoptosis, again in the pathways, what you have to remember, apart from pro-apoptotic and anti-apoptotic factor, is the initiation and executioner caspases. Very, very important. Okay. The initiation caspases and executioner caspases. The in intrinsic pathway, what is the initiation caspase? That is caspase 9. In some books, it is even 8. Whereas in extrinsic pathway, initiation caspases are caspase 8 and 10. So, just remember 8, 9 and 10 are initiation caspases. What are the execution caspases? That is caspase 3, caspase 6 as well as caspase 7. So, this can be asked. What are the initiator caspases and what are the executioner caspases? And naming of apoptotic body. Remember this. Councilman bodies are seen in yellow fever. Camino bodies. These are the different apoptotic bodies in different lesions. They have been given specific names. Okay. 3 apoptotic bodies and their conditions, their names. That is what you are supposed to remember. Councilman bodies, yellow fever. Camino bodies in case of Spitz nevus. This is a type of nevus. And civet bodies in case of lichen planus. Okay. So, please remember these 3 things. So, that can be a simple knowledge based question, right? So, this is what about BCL2 I was telling. So, I've got many answers. Very nice. BCL2, BCLXL, MCL1, all those. Please remember them as anti-apoptotic factors. Rest all, whatever options including Puma, Noxa. Okay. So, all those are pro-apoptotic in nature. The next question is a one-liner, straight liner, nothing to worry, and you have the same lines in the Robbins. Okay. Most common genetic cause of hypercoagulable state. Okay. Prothrombin gene mutation, protein C deficiency, Leiden, that is factor V Leiden mutation, antithrombin 3 deficiency. What do you think is the answer? What do you think is the answer? Very easy question. Most common genetic cause of hypercoagulable state. If you have studied it thoroughly, without wasting a single minute, you will mark this as factor V Leiden mutation because it's given as very good. Manaswini, this answer C is correct. Most common genetic cause of hypercoagulable state is factor V Leiden mutation. Very, very important. It's a straight liner. It does not require any effort. Okay, if you have read it correctly, you are going to hit it correctly, right? So, other causes will be prothrombin mutation. So, what it does, why it causes hypercoagulable state? Because of this particular mutation, that is Leiden mutation, now the factor V, which is in the active state, becomes resistant for protein C mediated lysis. So, it does not undergo inactivation, so that there is excessive factor 5A which is there, and that activates more and more thrombin generation. It's not going back to inactivated state, but more and more thrombin generation is there, and that's why the patient is prone for arterial as well as venous thrombosis, and more so in the younger individuals. And that's when you have to think of such genetic factor abnormalities as the cause for Thrombophilic states. Okay, so important cause of hypercoagulable states. If we look at the primary cause, factor 5 mutation or lead-in mutation is at the top, and that's the most common. Okay, remember it, and you can just refer or look into the secondary causes of hypercoagulable state in my notes also. Okay. Next question is very, very interesting, right? Lack of CD40 ligand in B lymphocytes. So, B lymphocyte now does not have CD40 ligand. So, this is a situation here we have a B lymphocyte and there is CD40 ligand is missing. Now, if 40 ligand is missing, what happens is it cannot get any help from T cells. Remember this, very, very important. Now, if it does not get any help from T cells, what will not happen is there is no class switching. It stops, it can't change its antibody types. Okay, only IgM, because it is synthesized in the beginning, it will remain, but it can't go to G, A and other type of antibodies. Very, very important question. Lack of CD40 ligand in B lymphocytes. They are asking actually the question related to hyper IgM syndrome in a different way. It comes under which topic? Very, very important. This comes under primary immunodeficiency. So don't ignore that topic, though it is very volatile and very difficult to understand and very dense. Okay, you need to spend time with such topics and do it again and again so that you succeed in answering such questions. And if you answer such questions, it makes a huge difference, right? So with respect to your rank. So this is actually lack of CD40 ligand, no help from T lymphocyte, there is no class switching. Okay, so this is what you need to understand, and that's the end of the story. It is nothing, no way related to T cells or neutrophil response to infections or NKT cells. Okay, so in primary immunodeficiency, I'll just tell you what is very, very important and what you have to concentrate. Now, severe combined immunodeficiency, as the name indicates, there is both the cellular, the adaptive immunity, the cellular immunity as well as humoral immunity is affected, and this is, it can be autosomal recessive or X-linked recessive. What happens here is accumulation of deoxyadenosine, which is toxic for those lymphoid cells. Okay. Next is X-linked A-gamma globulinemia, which is also called as Bruton A-gamma globulinemia. What happens there is the precursor B cells are not getting converted into mature B cells. Remember this. So you have a condition where there is absent or the reduced mature B cells in the peripheral blood. This is very, very important, and that happens in Bruton A gamma. As the name, A gamma globulinemia. So no gamma globulins. Why it happens? Because precursor B cells are not differentiating into mature B cells. Why is it? What is the problem? There is deficiency of Bruton tyrosine kinase enzyme. Okay. Then DGeorge syndrome. There can be question on this. DGeorge syndrome is very, very important. That is deletion of TBX1 and other genes at chromosome 20. This is very important. Deletion 22q11 is something very, very important, which affects the organs which develop from third and fourth pharyngeal pouches. Okay, remember this, so that it affects the ultimobronchial, bodies, parathyroids. The patient suffers from hypocalcemic tetany, and in the history, there are chances that you will be given a scenario there is absent thymus, heart defects are present. In this case, there are reduced T cells in the peripheral blood. Remember this. That is DGeorge syndrome. This is hyper IgM. Just now we encountered one MCQ. So absence of CD40 ligand. So there is no help from CD40 lymphocytes, and naturally there is no class switching or affinity maturation. Very, very important. Hyper IgM syndrome. And lastly, CVID or combined variable immunodeficiency. B cells are abundant, but then they are not getting converted into plasma cells. So this is what you need to remember in this case. Okay, there is no change from B cells to plasma cells in case of combined variable immunodeficiency. Okay, so this is a table which you have to literally go through and slowly understand what are the defects in various different types of immunodeficiency. Though it's a denser topic, it is a very important topic, and you can expect at least one question in such exams. Okay, which of the following genes is responsible for regulation of T lymphocyte in the thymus? Very, very important concept of immunity, that is central tolerance as well as peripheral tolerance. If you have read central tolerance, okay, that is education of thymus, you know that the T lymphocyte are getting educated in the thymus, and those which are recognizing the self antigens are either deleted there. Either they are deleted or they are modified into what is known as T regulatory cells, which are FOXP3 and CD25. positive. So what is the gene which is responsible for this is autoimmune, AIRE, autoimmune regulator gene. Very, very important. AIRE is the gene. This, if you have not studied, then everything looks like, Greek and Latin. It's very difficult to answer. If you have studied and if you just know the full form, yes, something related to autoimmune is also there. The answer is AIRE. Other genes are no way related to this kind of, central tolerance. So this is a picture which shows you the mechanism of central tolerance and peripheral tolerance in the pathogenesis of autoimmunity. Again, this topic is very, very important, right? So AIRE, if there is a germline loss of this particular gene, then it would result in what is known as autoimmune polyendocrine syndrome. And FOXP3 is a marker which is present on regulatory T cells, which also has CD25 on it. And if it is not there, then it would result in what is known as IPEX syndrome, right? So these two are something which I felt is very important and you should be aware of, right? Which type of ANA staining pattern is seen in the image? Again, this question is very, very important. Okay, so something vaguely you can appreciate here. So you can see that it is somewhat like speckled. Okay, multiple dots are present and this is black, and then you are seeing the shiny green dots, then you know that it is immunofluorescence. But when you see this kind of spindle, okay, something like spindles, you should be sure that you are not actually dealing with the speckled pattern, rather you are dealing with centromeric pattern. There is hardly any difference, much difference for inexperienced eyes to appreciate the speckled and centromeric pattern differences. But if you see something like this along with this, then you are probably dealing with centromeric pattern and not speckled. If you're seeing only this, then you're probably dealing with speckled pattern. What is diffuse? If it is entirely filled like this, okay, then it is diffuse pattern. Nucleolar, of course, will look like one or two dots, okay, big dots within the nucleus, right? So that is nucleolar pattern. This is something which you have to do, okay. What are the importance of these patterns? So this I have already told you. This is the diffuse pattern. Where do you see diffuse pattern? Whenever you see diffuse pattern, this is seen in SLE, but you expect that there are antibodies which are against the histones and then against the double stranded DNA. So that is important. Next is the speckled pattern. This is the most common pattern but least specific pattern. If you see carefully, still the nuclear lobes are visible in speckled pattern. That is not the case in case of anti-centromere pattern. Okay, so that's important. This is the most common pattern, but it is the least specific pattern. And remember that non-DNA substances, like if you have the SSA, SSB as well as Smith antigen, all those will take a positivity for this. And what is this? You can see one or two big dots. This is anti-nucleolar pattern which can be seen in some case of mixed connective tissue diseases as well as in case of systemic sclerosis. Okay. And lastly, if you see that anti-centromere pattern, what I told you is very important. If you see something like that along with speckled pattern, yes, you are actually dealing with anti-centromere pattern. Okay. So remember all these things. And apart from this, what antibodies or what substance we are targeting? In homogeneous, it is antibody to histone and to some extent double-stranded DNA, but rim or peripheral staining pattern is actually for double-stranded DNA. So that is what you need to remember. Antibodies to double-stranded DNA, we can alone tell in rim or peripheral staining, whereas homogeneous is both for histones as well as for double-stranded DNA, right? And centromeric pattern, as I already told you, for centromeres, again in limited systemic sclerosis, you can get this pattern. And nucleolar pattern is seen when there are antibodies to RNA. Remember that what is the most common pattern? Speckled pattern, but it is least specific. It actually shows us all the non-DNA nuclear constituents. So this is what you need to remember. And here I have given you common antibody types in SLE, so you can have a look into it, but never ignore this antibodies in various mixed connective tissue diseases and their patterns, interpretation. That's very, very important. Now, we go back to amyloidosis. A patient on long-term hemodialysis due to renal failure is likely to deposit which type of amyloid? Students, I am waiting for your response so that you can answer. I have already told you what you can expect in amyloidosis, what are the different amyloid proteins that are present in different conditions. So, patient is on long-term hemodialysis. Okay, he is suffering from renal failure. And because of this, what you can expect as the amyloid deposition? I'll come back to this question if somebody answers this, right? Now, true about amyloidosis, again, all that is over. Manaswini, very good. A is the right answer. Amyloid beta 2 microglobulin. Where do you see light chain? It is in case of primary, in multiple myeloma. Amyloid transthyretin, I have told you, two conditions, senile systemic amyloidosis and One more condition is familial amyloidotic polyneuropathy, where you have mutated transthyretin, amyloid A in secondary amyloidosis. Okay, so that's how you can easily remember. Now, this is also over, right? Amyloid is an extracellular protein, correct. Starch deposition is present. It was actually thought that initially amyloid, that's why it is given amyloid-like. Okay, it was starch-like. That's why Verco tested it with lugol iodine. It gave the brown color. Then he added sulfuric acid. It gave the blue color, and that's why he called it as, it is something like starch, and he gave the name as amyloid. Who is Verco? Rudolf Verco is the father of modern pathology, and we should always remember such contributions and stories so that we can link, wherever we read such things, right? Rudolf Verco actually deduced that testing of amyloidosis in the gross specimens with Lugol's iodine. Okay, so you will definitely see beta plated sheets on X-ray crystallography. This is very, very important. And what is the length of amyloid fibrils? If somebody asks you, it is indefinite length. And what is the width? It is 7.5 to 10 nanometer. It's very, very important. It is indefinite length and it is non-branching in nature. AL type is secondary type. This is definitely wrong, right? AL type is seen in primary amyloidosis. Very good. Again, I got the answer from Renalini. D is the correct answer. So, rest all appears to be true in this case, right? What is the stain used in the image given below? The image is not very clear, but you can see that there are black color, like there are black color. See markings like thing on the pink background. So, is it amyloid? Now, we are familiar with the amyloid. Is it amyloid? No, it is not amyloid. You are sure there is no congruent staining, right? It is not there. H&D, is it H&D? You have seen lot of histopathology slates. It is not H&D. Is it elastic fiber? It is looking blackish. Possibly you are not sure. Collagen, again you are confused. Is it? No. Now how to approach this? How does collagen look? Either greenish, turquoise green or bluish. Which stain? It can be, it is a specimen, the section from cirrhosis of liver. You can see nodules of variable sizes, and I am showing this fibrosis with this particular stain. What is the stain used? Students, please guess the stain. It's very, very important. I have told you that is a section of cirrhosis. Now what is the stain used? Please help me in this. Okay, so that's with that stain we demonstrate collagen. Whatever bluish thing you are seeing here is collagen. Okay, so we did not see anything blue in our slide, so it is not collagen. Actually what we looked into was elastin. So what is the different elastin stain is? Verhoef's elastin stain, Verhoef's VG stain or a Van Giesen stain, and then Wiegert Van Giesen stain. Very good. Manaswini again gave the answer as Mason trichrome. Amazing. So this trichrome has three different colors, one for the nucleus, one for the collagen, and the other for RBCs. Very, very important. So this collagen either takes up turquoise green or blue color depending on what color you are using. Okay, and then you have a red color, and nucleus we use iron hematoxylin, so it takes up the black color, and that's how Mason trichrome is used for the staining collagen. Remember this, very, very important. Rest all were the elastin stains which I have already mentioned, and the given picture actually shows the elastin stain. Now it's a simple quiz for you. I want all the students to get engaged and answer, because many a times these questions have been asked. If this is a hemosiderin, now you can see that there is a brown pigment within. Okay, so these are heart failure cells in case of CVC, lung. Okay, so you have these heart failure cells. You want to demonstrate hemosiderin pigment. What is this special stain used? Any answer here? So answer that question. And this is the melanin pigment. It's a very dark brown in color, and it's melanoma. And this is a plant cell appearance hepatocytes with a glycogen storage disease. So what is the stain that I have used here, and what are we demonstrating here? This is the paranuclear pigment, okay, which you can easily see in the heart, and this is responsible for brown atrophy. So what is a pigment are we talking about? What is this structure and how we can demonstrate this concentric whirl like appearance, and what is this blue again? Okay, what is this special stain which is used here? I'll wait for some more time and come back to this question as I see answers. Okay, you just randomly can give the answers. One for hemosiderin laden macrophages, 2 is some paranuclear pigment, 3 is for this blue color, 4 for this brown color pigment, 5 for this concentric lamellated bodies, and 6 for this plant cell appearing thing. Yeah, number 2 is lipofuscin. Very good. It's a wear and tear pigment. When it gets deposited in the heart, we also call it as brown atrophy. Okay, you can see even in the mainly in case of testis also you can see this, and these pigment indicates that the wear and tear, okay, aging. It's also called as aging pigment. We don't use the special stain because it's quite obvious on the routine microscopic examination. Do we know the special stain for this? I'll tell you this. Von Cosa or alizarin red, you know that this is a calcium, which is samoma body, which is nothing but the lamellated calcium, which is arranged in the form of concentric circular rings. So that is the special stain. There is the von Cosa stain or alizarin red is what is to be used. What is the special stain for this? Number 4. Please answer this. By then I'll complete all this, right? So melanin, hemosiderin, hemogentisic acid is something which we did not cover. Please remember this. This will result in a condition called as ochranonin, and that condition is known as alkaptonuria. And do we know the answer for this? What is the special stain for bilirubin? Okay. So please think about all those things, and it needs to be remembered and images to be seen again and again so that you don't forget it. Brown atrophy, remember lipofuscin is deposited, not hemosiderin or any other brown color pigment, right? So again, going for the simple match the following question here. Trinucleotide repeat, trisomy 18:13, HB beta chain abnormality. Very, very simple. So you can expect some simple questions also when you're solving, the intense topics or the dense topics, amidst which, if you see this, we call this as breathers. Okay. So trinucleotide repeat naturally for Huntington syndrome, trisomy 8 for Edwards syndrome, trisomy 38 for, I think everybody remembers this way, E for 18. Okay. 13 is Patos, and you know that beta chain abnormality is seen in sickle cell. So you should never miss such breathers which come in between and hit it right and don't go wrong there. Trinucleotide repeat mutations are those diseases which are inherited in a non-classic way, that is called as non-classic pattern of inheritance. Okay, so you can expect these trinucleotide repeat mutations to occur in the non-coding region or in the coding region. Remember that those who occur in the coding region where we have the repeats of CAG, wherein in non-coding region it is different. For Fragile X syndrome it is CGG, Friedreich's ataxia it is GAA, and myotonic dystrophy T is there, that's how I remember. Usually the C and G are the combinations which are present. Okay, and this trinucleotide repeats, you need to remember that it follows skip generation pattern. That is very, very important. And Fragile X syndrome is a prototype of this particular disease, which you need to remember. And then anticipation. What do you mean by anticipation? That is, severity of the disease increases as the generation passes. Okay, so that is nothing but the anticipation. And it is said that in case of Fragile X syndrome, the trinucleotide repeat amplifications, they occur in oogenesis. So this is one of the important disease that is with non-classic pattern of inheritance. This is non-Mendelian. Okay, this does not follow the Mendelian law of inheritance. Okay, so the very good students are actually answering the question on special stains. So Mason-Fontana stain for melanin. Very good. So this is Mason-Fontana. It is solved. And somebody answered Pearl's Prussian blue for this. Yes, hemosiderin laden. And this is actually a Pearl's Prussian blue stain in case of paroxysmal nocturnal hemoglobinuria in renal tubules. And I will tell you in case of glycogen storage disease, what you can use to demonstrate glycogen is periodic acid shift, right? So you can use this and treat with diastase and see whether it's really glycogen or some other. If it is, digested with diastase, yes, it is glycogen. If it is not digested with diastase, it is not glycogen, but it is some other thing. Okay, so that's how you can use special stains and demonstrate various pigments. Pigment is a very important topic for your entrance. You have to practice seeing those images and remembering the special stains. It's not difficult, right? Is 8 again a simple question. Abnormal folding of proteins. Which diseases? Cirrhosis, you have studied in and out about cirrhosis. So you know that it is not because of abnormal folding. Nephritic syndrome, definitely not. There is a glomerular inflammation. Sickle cell anemia, you are thorough. Beta chain, 6th position, valine glutamic acid, right? PAS, very good. Nafis, so the PAS stain, we just finished with the conversation. So you are thorough with all this. Prion diseases are example of misfolded proteins. Remember this list: Alzheimer's, Parkinson's, prion. If you remember prion, Parkinson's, I think most of the questions. Alpha-1 antitrypsin, transthyretin. You can look at the options and just, find out the answer by the exclusions. Okay. Pedigree, I have already told you, so I am not going to repeat it again. But this question is important. 47-year-old person post-renal transplant was investigated. Now, post-renal transplant, usually what you expect is BK polyoma virus to be present, which are called as decoy cells. Okay, that is more common when compared to CMV in urine. But what they have told is on urine examination, there are cells with classic owl's eye inclusion. Moment you see owl's eye inclusion, what are the things that you get? One is CMV, cytomegalovirus inclusions, which are owl's eye inclusions, intranuclear eosinophilic cytoplasmic inclusions, which is very, very important. Okay, you can never forget this. What else looks like owl's eye? I'll leave it to the students. I'll wait for you. Okay, give some examples in tumor where you see this owl eye like inclusions. Okay, CMV, human papilloma virus. Human papilloma virus, three things you have to remember. Triple M. Okay, nuclear molding, margination, multinucleation. So that is a feature of human papilloma virus. Are we seeing all that? We are only seeing inclusions. Moment I say owl eye, it is CMV. Epstein-Barr virus, what you see, prominent immunoblasts you can see, enlarged nucleus with prominent nucleoli, but even Donny cells you can see, skirt-like border of the atypical lymphocytes you can see, but not inclusions like this. So with that, what is the answer? CMV is the answer. If it is BK virus, what it gives is the decoy cells. Remember this. Next time the question can be urine showed presence of decoy cells. Why they are called decoy? Because they deceive to be a malignant cell. That's why they are called as decoy cells. There you see the ground glass appearance of the nucleus with moderate amount of cytoplasm. This is how a decoy cells look. That is because of BK virus or polyoma nephropathy. Okay. So very good, Manaswini. Again, Reed Sternberg cells are one cell which again looks like owl eye. Okay. Mirror image nucleus with prominent eosinophilic nuclei. Exactly like that. If you see in case of infection, inclusions, eosinophilic inclusions, we are actually dealing with CMV. In my notes, I have given lot of such bodies. Okay. Leishman-Donovan bodies, owl eye inclusions, lot of such things have been given. Please go back and refer in my notes. This is again one of the important repeats. Like I have 3-4 questions based on the same image. Okay, this is very, very important. Dermatology department, 10-year-old child presented with multiple small papules on the face, and this was the lesion. In some of the questions, there are more clues. Okay, this is the lesion. Now look into one more question where they say that multiple skin lesions are present on inner thigh and genital area. Okay, and central umbilication is also present like this. Okay, and histopathological image is given. Okay, this is also one more question. Now one more question is again inner thigh, you have a lesion. Histopathological image is given which shows multiple intranuclear inclusions. Large inclusions are present. Okay, which are consistent with, they have even making it very, very easy, Henderson-Peterson bodies. So conclusion of all three questions together, if we want to put it in one condition, what is the diagnosis? Can anyone tell me? So in one question just showed the image and said that there is a lesion. Second question they told it is an umbilicated lesion and it is on the inner side of the thigh and genital area. They gave you the histopathology image also. Third, they gave you one more clue telling that there are Henderson-Peterson bodies. So what is the diagnosis, students? Such a easy question should never be missed. We are all actually talking about molluscum contagiosum virus, pearly white umbilicated nodules, children, okay, and extremities, neck, axilla, face, genitals, all those are involved, and in this intracytoplasmic eosinophilic inclusions in the keratinocytes, which are usually involving the stratum spongiosum, and as they involve the granular layer, okay, what happens there is they turn more basophilic. Otherwise, they are pretty pink eosinophilic, something like this, as you can see. These are nothing but molluscum bodies or Henderson-Peterson bodies. And never miss, if such a easy question comes, it's very, very easy to crack. If you are familiar, umbilicated Henderson-Peterson bodies, eosinophilic inclusions within the keratinocytes, and then if it is on the genitalia, it's even more easy. It's all leading and you have to get it right. It has molluscum contagiosum, right? So that's the answer. Metastatic calcification. This is also one more very, very important area, students. So they're asking metastatic calcification is seen in all these conditions except. So this is very, very important. Renal failure, vitamin D disorder, hyperparathyroidism. In all these conditions, we see some amount of hypercalcemia will be there, right? Milk-alkali syndrome, if that is the option. What is something called as metastatic lymph node? To confuse you, they have given in the option itself metastatic, but that is not associated with metastatic calcification. You know that metastatic calcification occurs in conditions wherein there is increased levels of calcium. Why there will be increased level of calcium in metastatic lymph node, which is mainly a dystrophic calcification will happen because of dead and degenerated tumor cells, if at all they metastasize to lymph node. So this is what something you need to remember remember, and look carefully into the options and don't go by metastatic lymph node. I'm not sure about renal failure. No, no, no. You have to be thorough with the causes of metastatic calcification, concept of metastatic calcification, whatever the terminology it is. Never go, bypass the concepts that you have learnt and you have made it sound. Okay, so that has to be correct. And metastatic lymph node, there can be death of the cells, degenerated cells. So there has to be dystrophic calcification and not metastatic calcification. Okay, so metastatic calcification occur in normal tissues, and these are the important examples. You have done it several times, and dystrophic occurs in dead and degenerated. That's very important. Examples are atheromatous plaque, Monckeberg calcific sclerosis, etc. And what is this? Very, very important. I have already told you, samoma calcification, that can be image based. And for calcium, what are the special stains? Von Cosa, alizarin red. Okay. PSM is the mnemonic for samoma bodies. Where all you see samoma bodies, I leave it to students. I want them to answer at least 3 tumors where you see samoma bodies. Okay, while I discuss the next question, which is again straightforward and easy. Hereditary angioneurotic edema is due to deficiency of which complement factor. Again, never bypass this. Very, very important. Now it is called as hereditary angioedema only. Okay, it's only hereditary angioedema. This is very, very important. C1q inhibitor deficiency. All of you would have studied. What is the deficiency of CD59 is going to cause? That is paroxysmal nocturnal hemoglobinuria. And what is the deficiency of C2, early component of complement, going to cause SLE, right? So there are different diseases, but angioneurotic edema is because of C1q inhibitor deficiency. These are purely concept based and you are not going to miss it, right? It is all given in my notes. All of you can please go back and refer to these notes. C1 inhibitor deficiency, hereditary angioedema. So easy to crack. There is nothing much of logic here, and once you understand what is hereditary angioedema, how it happens, why C1q causes, but the question asked is what causes hereditary angioedema. So C1q deficiency or C1q inhibitor deficiency causes hereditary angioedema. Come on students, please tell me what are the causes of pseudomatous calcification. Very good. Serous cystadenoma, papillary thyroid carcinoma, malignant mesothelioma. Something which you have left in M is meningioma. Okay, so meningioma is an important cause. Okay, then never forget in P we have papillary thyroid carcinoma. This is something important. Then papillary serous carcinomas of the ovary, that is what you need to remember. Prolactinomas, they are also called as pituitary stones. Okay, you are not going to forget that. And S is actually for serous carcinoma of the ovary. Mesotheliomas, yes, more than that, meningioma is something which is very, very important. And even somatostatinomas. This, yes, apart from serous carcinoma, it is for somatostatinoma. So how much ever is possible, try to remember. But I request you, at least you remember papillary thyroid carcinoma, prolactinoma, serous carcinoma. Very good, Nafis. I could get some of the answers here. Meningioma is one thing, but many students forget, but don't forget. That is also one of the important cause for pseudomatous calcification. Okay, this is what I wanted to tell you. Interleukins are also very, very important, right? If you have read it thoroughly, if you have done it in your first or second chapter, yes, you are able to crack the answers perfectly. Interleukin 4. What do you know about interleukin 4? Interleukin 4 actually stimulates B cells to produce more and more IgE antibodies. Okay, this is from the Th2 helper cells. That is what you need to remember. What does IL-5 do? You know that it increases the proliferation of eosinophils. So it causes eosinophilia. Interleukin 9 and 13. You have no clue. You have read that 13 will cause more of, increases the mucus production. But remember that 13 is also responsible for the proliferation of this dendritic cells. Very, very important. And interleukin 9, something which you don't know, is related to mast cells. At least 2 or 3. If you can get it in the match the following, then you can actually do for the one which you don't know. Here in mast cells, definitely it's difficult to know here. Interleukin 9 is actually one of the cytokine which helps in the proliferation of those mast cells. Okay, so that is how you can actually relate. This is something with maths, that is numbers. You have to play again and again and try to remember what interleukin is for, what type of, whether it is a Th1, whether it is Th2 or it is Th17 cytokines, because many of questions have been asked in this particular topic. Okay, if I tell you interferon gamma, interleukin 12, interleukin 2, what are you answering? It is Th1. Okay, if I tell you interleukin 4, interleukin 5, okay, then what should be your answer? Actually, I'm thinking interleukin 13. It is Th2. Then if I'm talking about interleukin 17, you know that it is Th17. Likewise, you should be able to do it again and again so that you don't mess it up in the exam or you lose marks because of that. Okay, all of the following statements are correct about BRCA1. It's a very tricky question here. This helps in DNA break, correct? You have studied that. BRCA1, BRCA2, okay, ATM, all those, all those are involved in DNA break repair, correct? So that option is correct. Does it increase the risk of ovarian cancer? Yes, it increases the risk of breast cancer or ovarian cancer in the familial setting. Is it a tumor suppressor gene? And then mutation seen in subset of Fanconi anemia. Is it a tumor suppressor gene? Yes, it is a tumor suppressor gene. Mutation seen in subset of Fanconi anemia. Is it related to 2 or 1? Please tell me that. It is not related to BRCA1. Okay. It is only related to BRCA2. Okay. If there is a germline mutation of this, those patients are susceptible to develop Fanconi anemia. And now you decide actually which of the following are correct about BRCA. All of the following they have told which is correct, and which is incorrect is what you are supposed to tell. Okay. So like that you can actually give the answer. Now, this is about DNA repair. This is something which is very, very important. BRCA1, BRCA2, CHEK2, okay, MSH2, ML. I have told you mismatch repair, what are the ones which are associated, and what are the ones, that means the genes which are associated with repairs of double-stranded DNA breaks, okay, which is associated with familial carcinoma, breast as well as ovary. In fact, BRCA2 is more implicated in pathogenesis of male breast cancer, right? So you have to know in detail about BRCA1 and BRCA2, the location of the chromosomes, that is chromosome number 17 and 13 for BRCA2. And remember that BRCA1 is most commonly triple negative breast cancers, whereas BRCA2 is usually ER positive. This is something which I want to emphasize because in the upcoming questions, because the questions are now, if you look at the trend, it is on molecular subtypes, not on morphology, especially with respect to breast cancer. It's going to be genetics, molecular subtypes, or it is on prognosis. Okay, so you concentrate on this. It is triple negative BRCA1, whereas ER positive in case of BRCA2. Okay. Now, carcinogen associated with clear cell carcinoma of female genital tract. This is pretty simple. So, you get such breather slides in between and you have to look for the right time and finish it in short time. So, you know that it is stilbestrol, it is not alcohol, it is not oral contraceptive pills, and it is not tobacco. So, the entire list of chemical carcinogens and what is the cancer implicated. Out of that, few are very, very important. Now, if I ask you suddenly cadmium causes which cancer, it is difficult, right? You need to see it repeatedly. It is carcinoma prostate. Vinyl chloride, many a times it is asked, that is angiosarcoma of the liver. Benzene, it has already come in NEET PG, that is acute myeloid leukemia. Arsenic, if I ask you, it is carcinoma skin, lung, etc. Right? Polycyclic aromatic hydrocarbons, it is carcinoma lung. Aflatoxin, if I ask, it is carcinoma liver. So like that, you should have that insight, and grab it as early as you can and retain it and then answer it. So these things require repeated revision. Okay. Similarly, the cancers which are associated with chronic inflammation as well as the immunodeficiency diseases which are associated with cancers, that you need to revise and go back, just look into those notes and be thorough with those things. Yes. Next is, which molecule helps the leukocyte to roll over the endothelial cells? Basic question in inflammation, nothing much to explain. Okay, you know that there is margination, rolling, adhesion, transmigration, chemotaxis, phagocytosis. These are the 6 steps, right? It's very, very simple. What they have asked you, roll over endothelial cells. So what helps in rolling over endothelial cells? Is it integrin or selectin? Only 2 options that you have to think of. Nothing much. Okay, rolling over is loose, right? They're just giving shake hands, that is the endothelium and the inflammatory cell. It's not a tight hug that happens in adhesion. Adhesion because of integrin, selectin, rolling over. Okay, so that is what you need to remember, and that's the end of the story. What you have to really read here is, you have to be thorough with your concepts of inflammation, cellular event and vascular event, margination, rolling, adhesion, transmigration, opsonization and phagocytosis. Okay, so that you should be clear. And next is the selectins and integrins, which play a very important role in different steps. If I ask you here, and don't get confused, integrins are there on leukocytes, selectins are there on endothelial cells, platelets as well as leukocytes. Okay, and selectins plays a role in rolling if you see. Okay, whereas adhesion, this tight adhesion is like hug, okay, between the inflammatory cell and the endothelial cell, that happens only with integrins. Remember this, very, very important. And next is, many a times asked question is, what helps in transmigration or diapedesis? So the option can be either PCAM or CD31. Remember this. This is again a very, very important question. Okay, so that is about integrins and selectins, and there can be questions on chemoattractants and opsonins. So look at these concepts at leisure. it is very important that you understand what are anaphylotoxins, C3A, C5. When these numbers come, it is definitely confusing for many of you because there's so many interleukins, so many numbers. It is confusing. But yes, you need to remember this and you have to thoroughly revise those concepts again and again so that you don't forget, right? So which cytokine is not secreted? Again came Th1, Th2, Th17. So you are not going to leave this, right? Interleukin 12, we said it is from Th1. Interferon gamma, we said it's from Th1. Interleukin 2 is also from Th1 and interleukin 4 is definitely from Th2. Okay. So this is what I was talking about. Th1, I have already told you, Th2, 4, 5 and 13, 17 and 22 from Th17 and T regulatory cells, something which can be asked in the upcoming, in future exams in anywhere because they haven't touched it. Ch17 is over, 1 is over, 2 is over. Now what is left is T regulatory cells, CD25 positive, FOXP3 positive, TGF beta positive and interleukin 10 positive, right? Interleukin 9 for mast cells, I have already told you this is just a revision, and interleukin 13 increases the mucin production. Now I have got a few slides in the end which talk about systemic pathology and I will go to those slides directly, right? So one thing in GIT which is very, very important is 17-year-old who presented with abdominal pain and intussusception. There's a polyp and which got removed. So moment you see this, okay, there is a polyp in a 17-year-old. You can see this arborizing fibroconnective tissue. Okay, this arborizing fibroconnective tissue in the lamina. Do you see smooth muscle fibers in the lamina of the GIT? No. Why do you see that? If at all you see that, we will call this as hematoma, right? Ectopic rest of normal tissue is choriostoma, but normally present, but it is abnormal, okay, which is indigenous to tissue, but it is abnormally, haphazardly present. Then what you call this as hematoma. So that is nothing but hematoma. So we are dealing with the hematomatous polyp because lamina is showing lot of musculature and glands are not only in the mucosa, they are present here and there, beneath also, right? So we are dealing with hematomatous polyp. So which of the following is a adenomatous polyp? Is it a hematomatous polyp? No. Tubulovillous polyp? No, it is not. It is a type of adenomatous polyp. Inflammatory polyp? Is it a hematomatous polyp? No. Peutz-Jeghers polyp? Is it a hematomatous polyp? Yes. So that's how you get the right answer as Peutz-Jeghers polyp. So in hematomatous polyp, we have juvenile polyp and Peutz-Jeghers polyp. And in Peutz-Jeghers polyp, what are you going to remember? Everything in Peutz-Jeghers polyp is very, very important. But clinically, remember that hyperpigmentation of the skin and mucous membrane. So that can be a clue. And then the patient has got a polyp and they are asking you a mutation, that is STK11 or LKB1 mutation, and it is autosomal dominant in nature. And in one of the exams, what is the location of polyps in Peutz-Jeghers was asked. See, entire GIT, small intestine, stomach, colon, bladder. I think option was esophagus, wherein the polyp was not present. Okay, and they are also prone for developing malignancies in colon, stomach, as well as elsewhere, like sex cord stromal tumor. Everything in Peutz-Jeghers syndrome is very, very important. Okay, and for juvenile polyp, remember it is in the rectum, and where you have what is hematoma. Abnormal here is the irregular and cystically dilated mucin-filled, mucus-filled glands, or something abnormal in Peutz-Jeghers polyp. Remember Christmas tree appearance, which is very, very classical of this Peutz-Jeghers syndrome, where you have this kind of polyp, or this ramification of fibromuscular tissue amidst these glands, which are benign glands. Okay, so that is very, very typical of Peutz-Jeghers polyp. This is called as Christmas tree appearance, and you should never forget this. So this is the image of juvenile polyp. This can also be given. You have a lot of mucin which is filled, and irregular and cystically dilated mucin-filled glands are present. Okay, so that can also be a question in future where they ask you about juvenile polyp. That is also a hematomatous polyp, where you don't have much, until and unless it is a juvenile polyposis syndrome, you don't have much risk of malignancy when compared to that of Peutz-Jeghers syndrome, which there you have increased risk of malignancy, not only in the GI tract but also elsewhere. Okay. This question again, 60-year-old male, low backache, involvement of thoracic vertebra, so he has a fracture. Serum calcium, what do you think? 9 to 11 is normal. Here it is 13 milligram per deciliter, so it is increased. And then you have the total protein which is being given to you, which is increased, but the serum albumin is very low. Hypoalbuminemia is present. Urine protein is 3+. Which of the following is likely reason for his renal dysfunction? If you analyze everything, okay, so if we think of this crab, okay, what is C, what is R? There is renal failure, hypercalcemia, okay, and then you have lytic lesions as well as anemia, okay. lytic lesions in the bone. Everything is there in the history. So what are we talking about? Do we have an answer for this? So all crab, okay, entire thing is present. Hypercalcemia, renal failure is there, anemia is there, multiple lytic lesion in the bone. That is mainly involving the vertebra. That's the most common site in this particular disease. Are we talking about hyperparathyroidism? Are we talking about metastasis? Are we talking about milk alkali syndrome, or are we talking about multiple myeloma? Answer is very, very simple. All four are fulfilling actually for multiple myeloma. It's not at all very tough. So multiple myeloma is one of the important areas where you can't ignore it. Okay, the questions can be like Bence-Jones proteins, where we have excessive light chains which are excreted in the urine. What is a M protein, which is nothing but the monoclonal immunoglobulin. CRAB, I have already told you. If CRAB criteria, if you are able to pick it up in the history itself, yes, you are dealing with multiple myeloma. The question can be, what is the cytokine involved in excessive proliferation of those plasma cells? The answer should be interleukin 6. And what is the minimum number of atypical plasma cells which are required in the bone marrow for diagnosis? Remember that it is 10%. At least 10% or more than that atypical plasma cells in bone marrow are diagnostic of this particular condition. You can see Dutcher bodies and Russell bodies in atypical plasma cells. Remember, Dutcher bodies are intranuclear inclusions, if you see the inclusions within the nucleus, whereas Russell bodies are intracytoplasmic immunoglobulin inclusions. Okay, apart from that, you can see flame cells or Mott cells. You can be even given the electrophoresis picture. Okay, you can see that now it is immunoglobulin G and kappa. Okay, so this combination, and this is how you can make the diagnosis of multiple myeloma. So there can be variety of questions on this particular entity, mostly image based, okay, where atypical plasma cells are given, or clinical scenario based question is what you have to anticipate. I have already told you that karyotype based questions can also be given to you. So here what you can see here, very, very important. Yes, x is given and 2xy. We have already completed this. That is 2x and y. What are we dealing with? We are dealing with, yes, I'll wait for this because I have already explained to you. So this patient, what is expected finding in this person who has 2x and 1y. Please have a careful look into this karyotype which is given to you. Web neck, is it seen? Flat occiput, polydactyly, gynecomastia and thin limbs. Okay, what is the expected answer? I'll leave it to you students because we have already had an intensive discussion on this. I don't want to leave this question because this is something again concept based. Very good, Nafis. Thank you for answering. Ashutosh, I think you did not get it. Web neck. Okay, web neck. I am going to repeat it. Web neck is a feature of Turner syndrome. And what are you showing? What are we showing here? In the karyotype is 2x and y, not x0. Okay, y, that is for Klinefelter syndrome. So Klinefelter syndrome in males, and what we expect there is gynecomastia and thin limbs. Polydactyly is probably in some trisomies like Downs, Patos and Edwards. You might expect flat occiput is not a feature. Web neck is a feature of, I have already told you, it's a feature of Turner syndrome and not Klinefelter syndrome. Okay, and no worries, you have to make mistakes now so that you improvise later and you don't do that again in the finals. That is very, very important, right? So we have already discussed. This question is again concept based. G6PD deficiency. You cannot leave any of the types of hemolytic anemia. Hereditary spherocytosis, then you have G6PD deficiency, sickle cell anemia, thalassemia. All four are very, very important. And then comes paroxysmal nocturnal hemoglobinuria, immune hemolytic anemia, right? So now I have got the answer for this question as correct. That is, which of the following is the effect of G6PD deficiency? Look into this option. Again, it is confusing. Increase in reduced glutathione. If glutathione reduced form was available, then there was probably no such difficulty was there. So this is wrong. There was no oxidative stress, so right? There is no damage to the RBC membrane. Decrease in lipid peroxidation. No. There is increased peroxidation. There is damage to the RBC membrane. So that is what we are expecting. So these cannot be, the correct options. Now, decreased RBC membrane damage. No, these go hand in hand, right? So if this is wrong, then this is also wrong. Decrease in NADPH. This is the major problem here. Hello. To one of the students who joined here. Decrease in NADPH, right? Decrease in NADPH is the major problem here. So that is not actually causing the enough of, the reduced glutathione to be present so that the RBC membrane damage is prevented. That's not happening. So understand this G6PD concept, very, very important. So what is the problem when G6PD is not there? You don't have enough of NADPH and most of the glutathione is going to, remain in oxidized form and and not in reduced form. So that is the only concept. Okay, there is oxidative damage, and why it happens is some of the drugs which are implicated, this is usually on and off. The chronic hemolysis happens, and it is only episodic type of hemolysis, and that can be both extravascular, intravascular, and exposure to fava beans drugs. So there can be a history. Some drug is given and the patient is presenting with hemolysis, and you have been, which cells are characteristic of G6PD deficiency? Students, kindly answer, those who are alert in this session till now. Thank you so much for being with me. Please answer. I have just 4 MCQs to complete. I hope you cooperate. Okay, primaquine, chloroquine, and sulfonamides. Okay, so the drug units. I'm asking you, what is the typical morphology that you see in case of G6PD deficiency? I want your answer. Very, very important. I'll come back to that slide later. Right? Which of the following protein is produced by HPV? Haynes body is one important thing, but unfortunately, students, can we see Haynes body on peripheral smear examination? That's a very sad point about G6PD. We have to do very good. Haynes bodies, Ashutosh, Manaswini, both of you have answered. Haynes body is not a Leishman. You can't see it on Leishman stain. I want one specific pointer where you actually see something is removed by the spleen. Those Haynes bodies are removed by the spleen, and these RBCs look like dash. Okay, so those cells are seen in the peripheral smear as a mark of G6PD deficiency. I want your answer now. Haynes body is very good, but it is the supravital stain. What else you demonstrate with supravital stain? That is, reticulocytes are demonstrated with supravital stain. Very, very important. HBH inclusions are demonstrated with supravital stain, and Haynes bodies, that is denatured hemoglobin, is demonstrated with supravital stain. Bite cells is an excellent answer again, Manaswini. So bite cells look something like this, right? If you bite apple, just keep it, compare. So you have the same here. These are the bite cells. Who has bitten this? The spleen has bitten this. Why it has bitten? Because they had that abdominal Haynes bodies, that is precipitates of hemoglobin, and that's why it looks like bite cells, and that is very, very important clue for G6PD deficiency. And this is polychromatophils, indicating that the hemolysis is going on. Remember that it is self-limiting and episodic, and that's why in G6PD you don't have chronic hemolysis. Okay, moving on to this question and this concept again. Which of the following proteins which is produced by HPV suppresses RB gene, that is retinoblastoma gene? You know that LMP, what is latent membrane protein, this is not related to HPV. At least this much you are expected to know, because we can't go back to now. LMP1 is produced by Epstein-Barr virus, and there it induces chemical carcinogenesis. That can't happen. TAX is by HTLV1 virus, okay, which causes adult T-cell leukemia. LMP1 by Epstein-Barr virus, and that is implicated in many of the non-Hodgkin lymphomas, nasopharyngeal carcinomas, some of the variants of Hodgkin lymphomas. Hodgkin lymphoma is also one of the very important areas for your exam, starting from morphology to different types and what is caused by EBV, what is not caused by EBV. Please concentrate on that. Now we are left with only two options, whether it is E6 or E7. I always tell my students, if P53, 5 is close to 6. So just remember this, E6, okay, it interferes with the activity of P53 over. So E7 is the one, we are left with that, and that actually suppresses the function of RB gene. So what is important in biological carcinogenesis is what is the genome implicated, what is the cancerous agent or which infective agent is causing the cancer and how it causes, and what is the lesion associated. So never ignore this particular topic. I have told you E6, 6 is close to 5. Just remember that 6 for P53 and TERT, E7 reduces RB gene, okay, and Epstein-Barr virus, LMP1 and EBNA2, okay. The mechanism of action you need to actually go through and understand. Human papilloma virus is associated with squamous cell carcinoma of the cervix, that is high risk type, okay. If it is low risk type, if we are talking about low risk type, that is 6 and 11, then it is associated with genital warts, which we call as condylomas, okay. And we have one other variant, that is 1, 2, 4, 7, they just cause papillomas. They don't even cause condyloma or genital warts, like laryngeal papillomas are associated with such type of HPV, okay. So these are high risk type, which mainly suppresses the action of P53 with respect to E6 and RB gene with respect to P7. You need to remember this. Again, one more important immunofluorescence image based question. If you are seeing a fishnet, okay, so just remember this fishnet pattern. This is called as fishnet pattern, okay. Here the antibodies are against desmogleins. That is what you need to remember. So students, what are we talking about? What are we talking about in this condition? With respect, this immunofluorescence pattern, this is going to be an indirect immunofluorescence, okay, most of the times. And here you have these, the fishnet pattern. You can do it with diff or indirect. Mostly for the splitting studies, you have to go for indirect. Otherwise, you can do a direct immunofluorescence also. You have a bulla, okay, you can see here. And you above the basement membrane, yes, you have that separation. And here the squamous epithelial cells are showing fishnet pattern. So if you see fishnet pattern, you are dealing with pemphigus vulgaris. And if you just see a linear staining, okay, this is a linear staining at the dermoepidermal junction, okay, so then you are actually dealing with bullous pemphigoid. And remember that suprabasal bulla, they are within the epidermis, above the basement membrane. They are the characteristic features in case of pemphigus vulgaris, pemphigus foliaceus, etc. For mostly the entrance exam aspirants like you, the question will be either on pemphigus vulgaris, bullous pemphigoid, or sometimes linear IgA dermatosis. So concentrate on some of the images in dermatopathology so that you will be able to answer. And one adnexal the skin tumor which is important for you is basal cell carcinoma. Okay, never ignore that. I have not put it. And next is urine examination, some of the crystals that you can see. Okay, that is uric acid, calcium oxalate, triple phosphate, and cysteine are the option. Now, what is the answer here? Can any student try? We have 2 more slides to complete. Can we see that? Can any student attempt this? We have the envelope shaped crystals. So such crystals are also very, very important. All these are image based, so you have to spend time. Yeah, very good. Pemphigus vulgaris was the answer for that because of fishnet. Can we try? Nafis, this calcium oxalate crystals which are envelope shaped. Okay, right. Now, these are envelope shaped crystals which are calcium dihydrate crystals. This is very, very important. Calcium oxalate can be dihydrate or monohydrate. Dumbbell shaped are monohydrate, whereas dihydrate are they are envelope shaped. If we see coffin lid, I have left it unlabeled because of you, because for you students, what is coffin lid? Now, coffin lid crystals are seen in which, the crystal deposition. Please please answer. This is a very easy question. Okay, so I'll be waiting for your answer here. And the hexagonal crystals are typical of cystine. Again, important. Petal shaped or floret type, if you see this, then we can see this in uric acid. Okay, uric acid crystals. Then if we have some, I used to call this in my student days as broomstick. If I see something like bundles of needles, I call this as tyrosine crystals. And if it is something like thorn apple, no, then this is ammonium biurate crystals. Very good, Ashutosh, you got it right. Triple phosphate, Manaswini also has answered. This is coffin lid crystals. Okay, the coffin lid shaped crystals which are nothing but triple phosphate or the struvite magnesium ammonium phosphate or the triple phosphate. Very, very important. Triple phosphate crystals or coffin lid. So you already had question on this envelope shape. Next time you can anticipate question on the other things like the coffin lid shaped crystals or the leucine crystals, cystine crystals, etc. Right? So you have to be thorough with their morphology. Now, I want to tell you on this nodular lymphocyte predominant Hodgkin lymphoma and classical Hodgkin lymphoma. If you refer my notes, I have already given you the difference. But to emphasize, Hodgkin lymphoma is one of the very, very important topics that you should never ignore. Right? So, is it EBV negative? You know that nodular lymphocyte predominant and nodular sclerosis type are EBV negative, right? They are 1530 negative because that is non-classical type, right? And CD20 positive. Is it CD20 positive? Yes, CD20 positive. But what is wrong is poor prognosis compared to classical Hodgkin lymphoma. It always carries better prognosis when compared to classical Hodgkin lymphoma. The best is nodular lymphocyte predominant Hodgkin lymphoma followed by nodular sclerosis, okay? And next what you have to actually look into is the morphology and identification of different Hodgkin variants, that is lacunar cells, popcorn cells, then LH type of cells, all those type of cells, and where do you see them. This is very, very important topic. And this is, if this picture is given with some MCV of more than 110 femtoliter or something like that, this is again hypersegmented neutrophil. I am showing you again and again so that you don't forget those things which are very, very important, and don't keep it for the nth hour. You can do it now itself, and then in the end you can actually revise the tough concepts and those who need repeated memory based questions. You can keep it at the end and do it again and again. Okay, megaloblastic anemia is the right answer, Ashutosh. And you can expect question on thyroid function test. patient is having weight gain, lassitude, and investigations revealed increased TSH with low T4. What is the most likely diagnosis? By the moment you see low T4, yes, we are dealing with hypothyroid. Now look into the options: pituitary adenoma, hypoparathyroidism. They did not tell you about anything thyroid releasing hormone, only they told about TSH and T4. We can only relate two things better here, so we'll restrict our thinking to thyroid. Now Graves' disease, you know that it is hyperthyroidism, right? So you expect increased T4, increased T3, and low TSH. Now what you expect here is low T4 is there, definitely hypothyroidism. What is the one cause of hypothyroidism which is given is Hashimoto's. So you have to read thoroughly about Graves' disease as well as the conditions which are associated with hypothyroidism, and never get confused with the thyroid profile. Okay, forget about TSH. First think of, if it is hyperthyroid, you expect increased T3, T4, then think reverse, decreased TSH. That's all. If it is hypothyroidism, reduce T3, T4, then increased TSH. Okay, then causes. If it is hyperthyroidism, yes, it is toxic multinodular goiter, or it is Graves' disease, or sometimes functional adenomas. If it is hypothyroid, most common, important, very important autoimmune causes, Hashimoto's thyroiditis, or it is goitrogens, right? All those things which you can think of. Other areas, antibodies. Now, in this is been asked in one of the exams. What are the antibodies that you see in Hashimoto's thyroiditis? Antibodies against thyroid peroxidase, thyroglobulin, and anti-TSH receptor antibodies. So such questions you can expect both in TFT as well as in LFT. Okay, the gross and microscopy and Hurdle cells in case of Hashimoto's thyroiditis, oxyphil cells or Hurdle cells. Why they look eosinophilic? Because of abundant eosinophilic cytoplasm. One knowledge based simple question: most common retroperitoneal tumor. Does it require any revision? No. One or two times if you have studied, if you have heard, it is over. So what is the most common retroperitoneal tumor? I'll leave it to students. This is again very, very simple: rhabdomyosarcoma, neurofibroma, liposarcoma, synovial sarcoma. Somebody is answering it as B. B is the wrong answer. What is the tissue which is rich with? Only you have got a lot of fat and some tissue. Soft tissue tumor we are expecting here. So that is liposarcoma. Okay, it's purely knowledge based. If you have studied this, yes, you are going to answer it. Okay, regarding aging, sirtuins and telomerase is what you can expect the question. So the question is, all of the following are true about telomerase. Telomerase, is it reverse transcriptase? Yes. Does it have high fidelity in DNA synthesis? Yes. Only in eukaryotes. Very good. This is only seen in eukaryotes. That is very, very important. Is it involved in DNA repair? We studied about various, very good, Nafis. You answered it as liposarcoma. That's the most common malignant retroperitoneal tumor. Very good. Now, is it involved in DNA repair? We studied about various types of DNA repair, starting from double-stranded break repair, mismatch repair, homologous repair, non-homologous end joining repair, nucleotide excision repair. Did we study the role of telomerase anywhere? No, it does not play any important role. So what are those repeats? TTAGG are the repeats in telomeres. It has got reverse transcriptase activity. Highest telomerase activity will be seen in case of the embryonic stem cells. Very, very important. And also the gonadal cells, they also have that. But at somatic cells, the telomerase activity goes on decreasing until they attain senescence. And the number of times a differentiated cell can replicate, before it attain the senescence is known as Hay-Flick limit. That's like a biologic clock. Please refer to it. Hay-Flick limit. This is something important. Hay-Flick limit. Okay. And this has high fidelity in DNA synthesis and does not play any role in case of, the DNA repair. Something that is very, very important. Target cells, that where do you see target cells? You see in case of thalassemia, and where it is important. Why do you see that central target? This is one of the interesting questions. Target cells are due to X. You know that this is how a target cell looks, that is red in color. But why do you see that central dot? Is it because of hemoglobin? If you have that assumption, please remove that. It is because of excess lipid material which is from the membrane. Okay. So remember, this increased cell membrane to volume ratio is seen. Either gain of the membrane of the lipid or decreased volume will make target cell appear like targetoid. Okay, so that's the reason. Increased cell membrane material or the decreased, the cell volume will appear the cell to look like target. So this is what you need to remember. Okay, and JAK2 mutation is one more important area. Chronic myeloproliferative neoplasms, CLL, all those are very important areas that you have to look into. Okay, so JAK2 mutation is more commonly seen in which type of leukemia? So CML, yes. ET, yes. Polycythemia vera, yes. Myelofibrosis, yes. Everywhere you see CML, you know that BCR-ABL, it is Philadelphia chromosome. We are not touching that. Now, ET, PV and PM, in all those JAK2 mutations are seen, but most commonly seen in polycythemia vera. So, that's what I want to emphasize is you know the concept. But sometimes you need to go into the depth and find out which is most common, which is least common, because such questions have been asked. It is not sufficient to know that JAK2 is seen in myeloproliferative neoplasm. No, that's not the end of the story. If you do that, you will miss on such questions. You have to be more specific, and most commonly, you should have that interest. Is it uniformly seen in all or most commonly seen in? Yes. Very good, Ashutosh. Again, polycythemia vera is the correct answer that you gave. Okay. JAK2V61F, this particular mutation, very, very important, seen more commonly in polycythemia vera, followed by essential thrombocythemia, and then we have primary myelofibrosis. Okay. This is one more important question. I just want all of you to go back and find out more in detail about this, that is thromboelastography. Okay. If you want to study everything about the clotting, you want to study about platelets, coagulation factors, fibrinolysis, everything together in an emergency where the surgeon and anesthetist is probably waiting for some surgical intervention, and you have to do everything together. There, the PT, APTT, CT, you can't do everything together, right? They have asked you entire coagulation pathway together. So that is nothing but thromboelastography. So TEG is one technique where you study the efficiency of blood coagulation, platelet function, clot strength, as well as fibrinolysis in one go. Very good. Thromboelastography is the option. And next time they might give you a graph of thromboelastography and what are the parameters that we are looking for. R is one important thing that you have to see. That is, R is time for the initial clot formation. And this is where the maximum clot formation happens. And this is where the fibrinolysis starts. Okay. This is still the coagulation factor and the clot formation. And this is for fibrinolysis. So this graph is what I want you people to be familiar. Okay. Now moving to almost the last questions here. I will in the end I will tell you what is something which we have probably missed in the session, but you should not be missing. Okay. A female patient with metastasis of adenocarcinoma in liver. Female adenocarcinoma liver is there, that is metastatic, and cytokeratin 20 is positive, CK7 is negative. This has been asked in many of the entrance examination. Okay. So lung, colon, thyroid, breast. You know that lung TTF1 is the immunohistochemistry marker, napsin. Okay, this is for adenocarcinoma of the lung. Okay, if it is squamous, then you have to do P63 and then you have to do P40 and pancytokeratin. Okay, that is for squamous cell carcinoma. So you usually don't do CK20, CK7 like this if it is a lung tumor. Then colon, you can do CDX1, and you have read that colon tumor is CDX1, CK20 positive and CK7 negative. Thyroid, you have always read that TTF1 is positive, and if it is medullary, you go for calcitonin. If it is papillary, you have to go for again BRAF mutations. If it is follicular, you have to go for thyroglobulin. Okay, depending on that. Breast, you can do a mammoglobin, right? Usually you do hormonal, right? HER2, you will do ERPR, right? So always you have to remember this. What is CK7 positive, 20 positive? What is 7 positive, 20 negative, 7 negative, 20 positive? Here only when you are experienced, it's very easy to remember. Otherwise, for a student like you, yes, you have to do a repeated revision. And once I say colon 20 positive, with colon, its friend rectum is there. Very limited tumors, right, to remember here. See, there are many other tumors. For you students, I feel this should be sufficient, and most of the tumors have been covered in this panel. If it is 20 positive and 7 positive, ovary, okay, CA, pancreas, cholangiocarcinoma, and urothelial, urinary and genital system. That's how you can vaguely remember. Ovarian tumors and urothelial tumors are 7 positive and 20 positive. This particular table is very, very important, and you have to see every day. You have to see, last minute you have to see, because if you get a question, your logic may not work here until and unless you have worked with these markers or you have remembered and read it thoroughly many times. Likewise, you have lot of immunohistochemistry markers. Nowadays, the diagnosis is not just based on the morphology, that is histopath examination. Much happens beyond morphology in like immunohistochemistry, fluorescent in situ hybridization, and also immunofluorescence, right? Genetic studies, FISH, all those things are very, very important. So for you, it is immunohistochemistry markers. I have given in my notes also. Please go through all the immunohistochemistry markers. Neuroendocrine, very important. Chromogranin, synaptophysin, natural killer cells markers. Then we have the calretinin, very, very important. If you are getting a question on electron microscopy, either it is from renal pathology, or it is an image of hairy cell in hairy cell leukemia, or it is mesothelioma where you have long slender processes, okay, and you have a lot of questions from asbestosis like malignant mesothelioma, lung adenocarcinoma, and coal-workers pneumoconiosis. And IHC, if they ask you, then calretinin for mesothelioma is what you have to remember thoroughly. Okay, there you should not go wrong. So please try to remember as many immunohistochemistry markers for you. Okay, last question is on bone tumors. Now, gross specimen of a bone tumor at lower end of a femur is given. It's a 10-year-old child, and what is a likely diagnosis in a child? Okay, so you can easily look here that it is probably the metaphyseal in origin, and it is destructive, and multiple lytic lesions are there, right? And GCT, giant cell tumor, osteochondroma, chondrosarcoma. Chondrosarcoma do not occur at this age, so it is excluded. Osteochondroma, it is usually like a pedicle, and then you have this tumor. Okay, stalk will be present, so that is also not there. Giant cell tumor can be lytic in nature, right? You have options between them, but 10-year-old child, giant cell tumor usually after 20 or 30 years. Now, in a child, this lytic lesion is present, right? So you are probably dealing with osteogenic sarcoma. In bone tumors, what is important is the X-ray appearance. Students, can anyone answer if you are awake? Now, what is the X-ray appearance in Ewing sarcoma, osteogenic sarcoma, and giant cell tumor? If I ask you the giant cell tumor, it has to be A is the correct answer, Ashutosh. It is osteogenic sarcoma. So, if it is giant cell tumor, you have soap bubble appearance. If it is osteogenic sarcoma, you have sunray appearance, or the sunburst appearance. Very good, sunburst appearance in osteogenic sarcoma. And if it is the Ewing sarcoma, then you have onion skin reaction because of the the periosteal deposition or the reaction that happens. Okay, so in osteosarcoma, osteoid is the important thing that you have to remember. And in giant cell tumor is a giant cell, but giant cells are not onion peel. Yes, very good. Onion peel appearance in case of Ewing sarcoma. Akshay has answered. Very nice, very nice. Sunburst. Yeah. So, in bone tumors, what is very important is origin of tumors, from where they originate. If they say a child, diaphyseal tumor, and you are seeing a malignant round cell tumor, what is the diagnosis? Ewing sarcoma is a very important thing, and that is the diagnosis. Okay, malignant small blue cell tumor of bone, if they give you, for you, it is with some rosetoid and PAS positive material, diaphyseal tumor, onion peel appearance, all those, Ewing sarcoma, right? Soap bubble appearance. Then you have giant cells. They are not tumor cells. Background monomorphic cells are actually the tumor cells, right? Then you have got even the translocation, which will help you in the diagnosis. So all those things you can put it. This is the osteoid that I was trying to show you. And in osteogenic sarcoma, this is what is very, very important. Codman's triangle and this particular lacy osteoid material for osteogenic sarcoma. Okay, there are many of the giant cell tumors are there in bone. You can go through this particular list, and this is what we are talking about. Beautiful soap bubble appearance, as we can see. This is osteoclastoma. Okay, so we looked into so many MCQs till now, and I'll frankly tell you what I could not, because 2 hours is too much to tell you, but I think I have covered more than 100 MCQs, but still some areas I could not touch upon. Lung tumors, we have discussed about the IHC markers, but yes, morphology, their location, that is very, very important. And thyroid tumors are something very, very important. That is papillary carcinoma, follicular carcinoma, medullary carcinoma. They are very, very easy, and definitely you can read, on your own, and you can definitely refer our notes, which is there in Manipal Medes app. Definitely everything is given. All points are given. They have been highlighted. You have to go through, and you can take in your own way and revise it in your own way, so that you can remember. So the purpose of solving the MCQs, it helps in sound knowledge, excluding the odds, applying the related logics. Repeated revisions will definitely make you master in approaching such MCQs. And what is the advantages? You can anticipate, right, in future what can come, and you will develop a systematic approach of how you can act. And everybody has their own approach of reaching to a diagnosis, and nobody should counter it. But what should be really sound is your concept. That should be really sound. And till it is knowledge based, you can't help it. You have to remember certain things. If the question on hypersensitivity reactions and what are the diseases associated with, if the question comes on the different cytokines, their numbers and from which cells, you can't apply much logic in this. It's very tough. So it has to be memory based until and unless these questions are knowledge based. You have to remember this and you can't escape from it. Okay. And probably when you read it again and again, you will find logic one or the other day, or you will remember it better, like how you remember ABCD till date, without knowing. You have studied many years and now no effort comes. So that's how it happens. As is your pathology, so is your practice. So as is your pathology, so is your performance. Pathology is the one which helps in bridging, connecting the dots between your basic science and your clinical. Mainly, if your pathology is good, you are able to answer most of the questions from surgery, medicine, as well as the gynec related to its tumors, right? As is your performance, so is your result, definitely. As is your result, so is your seat, right? So everything is actually dependent on how you read, how you dedicate, how you approach the subject, how you take knowledge from everywhere, and how you clear your doubts, and how you make mistakes when you are learning, so that you don't make mistakes when you're actually facing the scenario. So I think this session was very, very beneficial, and I too learned a lot of things from you and from this opportunity, and I'm thankful to all those who were there with me and responded very well to the questions. Hoping to see you all again. And some of you are asking what should be the strategy for last days. Yes, for the last days, actually, you should be prepared from day one. That is what I'll tell you. You have to have a mental chart, or you can write it actually. Which area are you feeling difficulty? Some people are very good in memorizing, right? Once they read it, they are able to memorize, like in anatomy, anterior, posterior, medial, lateral. I've seen my friends, they used to remember everything so nicely, but some students are not. And some students are very good at their concepts. Once they learn concepts, it's never ever going to be shaky, right? So you have to actually decide what kind of a student you are. You should learn on your own, like whether you are able to remember everything memory based, or your concepts are strong. And like that, if your concepts are very strong, then you don't want to, you have to keep it for the last. Okay, keep all the memory related things in the end.